Good evening, dear doctors. The Healthcare is proud to bring you a very new format of webinar, Ultramaster series, in partnership with Imaging Masterclasses. In this new format, we will have multiple faculty sessions, case-based informative e-panel, and engaging Q&A session, where you get to ask questions and the experts will answer. Today, the theme of the webinar is Resolving Fetal Growth Conundrum. Through the webinar, we will cover the following aspects: a systematic approach to assess fetal age, screening, diagnosis, and staging in FGR, management, and best practices. Each of these modules have been carefully selected to add value in your practice. I would like to introduce our esteemed faculties, Dr. Chander Lulla from Mumbai, Dr. Vivek Kashyap from Delhi, Dr. Pooja Lodha from Pune, and Dr. Jimit from Mumbai. A very big welcome once again to all our faculties. I will now hand it over to Dr. Kashyap, who along with his session will also be a moderator of the webinar. Over to you, sir.
Well, thank you, Zinat, and thanks a lot to GE for this support. Actually, what we had thought a long time ago was the issues that we need a little different panel from the general webinars that we've been hearing and seeing. And this was that we should select a theme and tackle the issues from the basics. This one is extremely important because not only are we going to tackle the basics and the issues of biometry and Doppler, which is step one actually, and a lot of people, actually the entire fetal well-being depends on the correct biometry. So that we, Dr. Pooja from Pune is going to tackle that. Then of course the Dopplers that we are doing routinely, but we must remind ourselves that the reason for doing a correct Doppler and what is the new things that we can take out from a Doppler is an important issue. Then, of course, Dr. Chander is going to take us through the actual difference between FGR and SGA. But please let us remind ourselves that this is a conundrum which always is very, very confusing and overlaps a lot. So we need Dr. Chander to clear that out for us. But the issue of FGR versus SGA, the foundation is laid on correct biometry and correct Doppler. And then we reach out to whether this fetus is FGR or SGA, and then a stage-based management, because that is one issue that we face in our daily practices. And after that, we have some session on common case scenarios, where Dr. Jimit will also join us. And we are going to take you through very different cases where it's a late onset FGRs, an early onset FGRs, and issues such as this, which are extremely important. Also, we would be very happy to take your questions. And these questions we will take towards the end. That is that when the panel discussion goes on, I'm sure a lot of your queries will be answered in the panel itself. But for the others, we can always take these questions and we can address them. So to start and to set the ball rolling, yes, it's very important. The correct biometry, the difference between how old is the fetus and how the fetus has grown. And that is what Dr. Pooja from Pune is going to take us through. So over to you, Pooja, and over to you, please.
Thank you so much, Dr. Vivek Kashyap, sir. Thank you for giving this platform. It's indeed a pleasure to be with stalwarts like yourself, Dr. Lulla, sir, and Dr. Jimit. Is my screen visible?
Yes.
Yes.
Yeah, okay. So I can start. The disclaimer, as for any other webinar, the present webinar is for dissemination of scientific information and the relevant references have been cited where required. I do not have, and hence I'm not declaring any conflict of interest. Today, I shall be speaking on behalf of the fetus who asks a very important question: how old am I? It may sound very basic, but like Dr. Vivek sir said, Defining normalcy is probably the most difficult and vital part of any situation in fetal medicine. And I would like to take you through the basics of fetal growth and dating. So the outline of my talk today in this webposium, we would go through certain basic definitions of fetal growth and fetal size, accurate dating, rules of dating, ultrasound assessment of fetal size in the first, second, and third trimester, and how they are different in each trimester. Fetal size versus growth velocity. This is a very important concept because the next two talks and the whole panel and management of fetal growth restriction would depend on fetal size versus the growth velocity. And growth charts, do they give us hope or is it just a hype? These are the references which I have used for preparing my talk today. A lot of you who are hearing this webposium today are obstetricians, a lot of you are radiologists, and it's amazing that this platform is going to equally benefit both of you. For a lot of obstetricians who do your own ultrasounds, I would take you through very basics of measuring fetal biometry, whether to date, whether not to date, and how to date. Obstetric ultrasound has now turned into ultrasonic obstetrics. And all of us here, whether we are obstetricians, radiologists, fetal medicine specialists, we are all sono-obstetricians. That is the need of the hour. Some basic definitions. Appropriate for gestational age, an AGA fetus is the one whose size is within the normal range for gestation. Let us not confuse this. I've tried to oversimplify it because I'm only laying a ground for the next talk. A fetal growth restriction, it is a fetus that has not achieved its growth potential. And of course, large for gestational age, as the name suggests, is the fetus whose size is above the predefined threshold for its gestational age. So what is the role of ultrasound in determining fetal growth? We need to have accurate dating. We need to estimate the fetal weight, which is also the fetal size. And we need to know if the fetus is growing in a good optimal velocity. So these are the three aspects which we would be going through today. Now, why is accurate dating so important? Now, dating of pregnancy is extremely important to time appropriate antenatal care, to schedule and interpret the tests and ultrasounds. For example, your double markers, anomaly scans, your basic booking bloods, blood sugars, ICT in case of Rh negative, everything revolves around gestational age and the correct dating. And of course, the most vital reason why you need to have an accurate dating is to determine the expected date of delivery. So the fetus may not deliver on the EDD assigned, but we need to have a fixed cutoff against which we are gauging the growth of the baby, and this cutoff is the EDD. So to determine the EDD, we need to know exactly how old the fetus is. Of course, for interventions in cases of preterm birth, every day, every week matters. So if we just see between 30 and 32 weeks, even a difference of 1 day would improve the life of the fetus and reduce the morbidity by 2 to 3%. So that's the importance of the accurate dating. Of course, post-datism to give steroids and so many others, which give us a reason to really date the pregnancy well. There are certain rules that dating needs to follow. Now you change the estimated date of delivery, that is, you redate the pregnancy only if there is a discrepancy of 1 week between gestational age by her LMP and gestational age by her ultrasound. So if she is 13 weeks by her last menstrual period and she is 12 plus 5 weeks by the CRL measured at 12 weeks, do not go in and change the dates and add confusion. There has to be a difference of at least 1 week for you to redate the pregnancy. Otherwise, you just go ahead with the EDD, which has been calculated according to her last period date. Now, the best time to date a pregnancy is by a crown rump length during the so-called NT scan. So the 12-week scan that we do, which we usually perform between 11 and 13 plus 6 weeks, is the best time to date a pregnancy. A lot of you right now would be wanting to contradict me, saying that we call the 6 to 8 weeks as the dating scan, but I would come on to the next slide and try to tell you why 12 weeks is a better time to date a pregnancy than 8 weeks. Now, just in case that the NT scan is unavailable or missed, you can date by the early pregnancy scan. Okay. Now, in case she comes late, she presents to you for the first time at 16 weeks. She does not know her last period date. Suppose she is conceived in lactational amenorrhea or she has PCOS. She doesn't know her LMP. Or if the dates are discrepant, the best way to date the pregnancy after 14 weeks is by a head circumference. Okay. Now, 13 to 14 weeks, it is said that dating by CRL, that is a crown rump length, is equivalent to dating by BPD. So you could choose either. But just because all of us are now almost experts in doing a very nice NT scan and measuring the CRL, why not overutilize this section to give a good dating as well? Avoid dating in the third trimester. So suppose we are seeing a lady for the first time at 30 weeks or 28 weeks, avoid dating her by any parameter, not by head circumference, not by femur. What you actually do is, she comes to me today at 28 weeks for the first time. I measure the weight of the baby. I take AFI and Dopplers. I call her back in 2 weeks. And what I actually see is the interval growth between today's scan and the weight of the baby after 2 weeks. If it is maintained on the same curve, then I would presume and date her with the head circumference. Okay. So in the third trimester, it is not one parameter, but a serial measurement of interval growth at least 2 weeks apart, which helps us in dating the pregnancy and finding out the expected date of delivery. Of course, we all are aware that IVF pregnancies need not be dated. Just quickly, a lot of obstetricians are hearing here, so it would be useful even for the radiologists. Always be in a habit of asking the mode of conception. IVF pregnancies are relatively common nowadays. And how do you date them? The date of embryo transfer is what you ask. And on the date of embryo transfer, the embryo is already 2 weeks and 3 days in case of a day 3 transfer, and 2 weeks and 5 days in case of a day 5 transfer. Okay. So most of our softwares have something known as date of conception. That's where you calculate the date of conception according to the embryo transfer. And that's how you date the IVF pregnancies. You do not use CRL to date them. You do not use the LMP to date them if it is an IVF conception. So coming to the same debate as to why 6 to 8 weeks is not a good time to date a pregnancy. If you just see these two images, they are of the same pregnancy, the same lady at the same gestation. But if I just change the angle of my scan by 90 degrees, I would over measure the embryo. And if I don't, I would under measure the embryo. So come to this box here where I've put in pitfalls in dating by viability scan. You may include the yolk sac. It's hardly millimeters. It's just 1 or 2 millimeters at 5 weeks. So it's very difficult to actually delineate the crown and rump of the whole embryo to measure it. And sometimes you could include the yolk sac and overestimate the gestational age. It may sound really tiny and unimportant right now, but if that translates into dating, it could make a lot of difference, because a difference of few millimeters at 6 weeks can translate to as much as 8 to 10 days difference in dating at term, which means a lot, especially if there is postdatism or prematurity. Another reason is, like I told you, it is very difficult to define the end points very early in pregnancy. Under measurement is likely as the embryo is mostly in a flexed position, unlike the CRL at 11 to 13 weeks, where we anyways wait for the fetus to pose for us in a mid-post position, not hyperflexed and not hyperextended. Okay, now every time that we get a report from our radiologist, or every time that an obstetrician scans the lady to find out the weight of the fetus, be it any gestation, the fetus will give us a new EDD. The machine, the software will keep giving us EDD by LMP and EDD by USG. Do not fall prey to this trick by the fetus. The fetus is going to fool us every time with a new date. But remember this golden rule. once you have assigned an estimated date of delivery, it does not ever change again. Like I said before, the fetus may not deliver on that date, but the EDD remains constant. Now, if you keep changing EDD on every scan, you would never come to know if the fetus is growing large for gestation or small for gestation. Because every time the lady comes for a scan, you are assigning the date according to the weight on that particular day, which you are considering as normal. Okay, so you're going to miss a lot of early FGRs and probably large for gestational age as well. So as a rule, either do not date the pregnancy if there is less than 1 week difference between her gestational age by LMP and ultrasound, or if you have once dated it at 12 weeks, do not keep changing dates every time. In case your radiologist is changing dates on every scan, just pick up the phone. Every obstetrician has the right to demand from their radiologist. Just inform the radiologist that once you have dated the pregnancy at 12 weeks, in order to ease our decision making, please do not change dates of EDD on every scan. Now coming to certain further definitions, a single measurement. So a fetus has come to you today for the first time. You measure, the weight is 1.2 kgs. It only indicates fetal size. It corresponds to 28 weeks. It weighs 1.2 kg. It does not tell me if it is normal, not normal, if it's FGR, if it is LGA. Okay. Fetal growth velocity is the rate of fetal growth over a given time interval. Okay. For example, grams per week. If I have measured a baby today and it weighs 1.2 kilos, if I measure it after 2 weeks and if it weighs 1.5 kilos or 1500 grams, there has been an optimal interval growth of 300 grams over the last 2 weeks, which is more important than the 1.5 kgs today. Okay, so we'll come to the growth charts where I could elicit that better. Now, this is important because sometimes due to over-enthusiasm and increased surveillance that you think the fetus needs, you keep ordering for growth scans every week or probably every 4 or 5 days. It is extremely important that to estimate the actual fetal growth and velocity and to get an optimal trajectory of growth, we schedule the growth scans at least 2 weeks apart. ISWAC says 3 weeks, but sometimes it could not be practically possible to wait for 3 weeks to see if the fetus is growing. But a difference of 2 weeks is required to optimally gauge the interval growth. So coming to these terms, fetal growth velocity, interval growth and trajectory, which all mean the same. How can we achieve that? Is by plotting growth charts. In fact, if your radiologist or if you yourself release a report with growth charts, which are easily available on most of the ultrasound machines now, or even in most of the softwares, or even free of cost online, which I have put in the last slides, it's very easy to give a report because every time you did not need to go through all the 2 or 3 pages of the report. Just look at the plotting or the growth chart and you would know if the fetus is growing online or not. So basic principles, the growth or velocity is dynamic. A single and serial measurements at more than 15 days intervals are needed. If it continues to grow along the same range, it is mostly normal. The measurements that fall off the curve are mostly abnormal. Let's come to how it looks. Okay, so I've oversimplified this for a few of those who are not yet acquainted with this concept of centiles and growth charts. So this is the 50th centile, an average that is required by a fetus. This is the lower side of normal, which is the 5th centile, and this is the upper side of normal, which is the 95th centile. So any weight of the fetus once measured when lies between the 2 red lines is within normal range for that fetus at that gestation. Okay, there is no single number which is normal. 1.2 kg is normal at 28 weeks. No, even 1.1 kilo is normal, even 1.3 is normal. And that is because it ranges between the 2 red lines. Okay. Now these red dots which have come up, less than 5th centile is what is fetal growth restriction, and above the 95th centile is what is the large for gestational age, which we would talk about in the later lectures. Okay, so serial monitoring is important. As you see, the abdominal circumference on day 1 could appear below the 5th centile, but as you see her after 2 weeks, it's grown optimally. You chart that here. After 2 weeks, you chart it here. And you do not need to go in and manually chart this, but your ultrasound machine and your softwares do it for you. Okay, so can you see how beautifully the abdominal circumference has maintained its growth curve along this 5th centile? Okay, so this is probably either a constitutionally small or a healthy small fetus, or probably this is a delayed conception which has not been dated, and therefore it is being seen below the 5th centile but growing beautifully. So just to remember grossly, if a line plotted with growth is parallel to what you expect, you're doing well. Okay, now look at this. The abdominal circumference here starts off at 50th centile. We are very happy. It drops slightly, but it is still better than 5th centile. But just keep in mind, a drop in centile is also to be noted and red flagged. I see her after 2 weeks. It is now crossing the 5th centile. Any waveform, any growth velocity that is crossing my expected line is not doing well. Okay, and similar thing holds true for this AC, which is starting below 5th centile, getting worse as I scan her each 2 weeks. Okay, so it's not just one number of fetal weight which is important. It is not just the growth curve which is important. It is also a reduced growth velocity between 2 scans, which is equally important. Okay. Now, a few common scenarios here. All of you can see these green dots. The first chart here is the head circumference. The second is the abdominal circumference. And third is the femur length. So, although we are now done with words such as symmetrical and asymmetrical fetal growth restriction, they are still being reported in a lot of reports, and we need to understand what it actually means, because they could indicate different underlying pathologies. Asymmetrical means the head is normal, the femur length is normal, but it is the abdominal circumference that's lying less than 5th centile. This is asymmetrical fetal growth restriction. If you look at symmetrical, means it is symmetrically small from the head, it's less than 5th centile here. It's less than 5th centile on the abdominal circumference, and it's also less than 5th centile on the femur length. So these are symmetrically small fetuses. Now, if only the long bones are short, so if the femur is very short, as you can see here, but if the head and the abdomen are normal, you are probably looking at some skeletal problem, and you should red flag this fetus for skeletal dysplasia. Okay. Now, in case she is coming to us late in trimester and you try to date her by head circumference, you make sure that the head circumference and the femur length agree to each other. And if they agree, you are bang on your dating, and you do not need to worry about whether you've assigned her the right dates. In case there is a discrepancy in the head circumference and the femur length, you should then go in and see if you've taken your sections properly. The next few slides, I will tell you how to take proper sections. Now, in case you have dated the pregnancy by the head circumference, and if the femur is falling less than 5th centile, as I told you, look for skeletal dysplasia or trisomies, chromosomal abnormalities, or probably an early FGR. Now, if the femur seems normal, but the head is actually smaller than what it should be, you are looking at something known as a microcephaly, or go back and see the spine, there could be a neural tube defect. So this is a quick way to, which ISWAG has actually given in the basic training in 2019, where it tells you that when the fetus comes to you for the first time in 3rd trimester, try to make your head circumference and femur length agree to each other. And if they do, you are good on your dating. Okay. Now, coming to the technicalities of how to measure the fetal size, like they say, if you're going to do it, you should do it totally right, because every measurement is going to affect your fetal weight and the plotting by centiles that could really matter later in decision making. So in the 1st trimester, how do you measure the fetal size? By the crown rump length. These are the guidelines by Fetal Medicine Foundation, which most of you are aware. The image magnification has to be good. Around 60 to 90% of your screen should actually contain the fetus. The crown and the rump should be very clear. When to measure the CRL is between 45 and 84 millimeters, not less than that and not more than that. Fetal position should be midline and mid-sagittal. And fetal attitude should be neutral, neither flexed nor extended. Now, with the help of diagram, here I explain to you how to take an ideal CRL, because if you take a flex CRL of 45 and if you take a hyperextended CRL of 60 millimeters, there is a dating difference of 1.5 weeks, which, like I said, matters a lot towards the term for decision making. So be very sure you are dating it properly. The image should occupy 60 to 98% of your screen, as here. Your crown and rump have to be very clearly defined. And this is how you measure the CRL here. Just a quick guide. The amount of amniotic fluid between the chin and the chest should be approximately equal to the width of the palate. So you are sure that the baby is neutral and not hyperflexed or hyperextended. Okay. Now coming to the second and third trimester measurements. What you actually measure is the estimated fetal weight. And how do you do it? You take three major measurements. One is the head size, another is the body size, and third is the skeletal size. For the head size, you measure the head circumference, for which you need the biparietal diameter. For the body size, you measure the abdominal circumference, and for the skeletal size, you measure the femur and humerus. This is something that all obstetricians should be aware of with precision in millimeters, because you all are going to do your own well-being scans from the second, third trimester onwards. Now, this is the plane you require to measure a good biparietal diameter. Biparietal means starting from outer edge of the bone here to the inner edge here. This is the biparietal diameter. And how do you get this plane? This is a diagrammatic representation. This space here is the cavum septum pellucidum. This is the thalami. The slit-like part here is the third ventricle. This is the posterior horn of the lateral ventricle. And this is the whole skull bone here. So you practice again and again, and this is the image you need to take for a very good biparietal diameter. Now coming to the next one is the transcerebellar diameter. Again, you need to have your cavum septum pellucidum here. These are the thalami here. These are the cerebral peduncles. And this is the cerebellum. The hyperechogenic middle part is the cerebellar vermis. And from this point to here is the transcerebellar diameter. Although not mentioned in any guidelines, but from 16 weeks to 24 weeks, the TCD, the transcerebellar diameter, beautifully correlates with the gestational age of the fetus. So at 19 weeks, the TCD measures 19 millimeters. At 23 weeks, it measures 23 millimeters, and then it gets skewed. So this is the transcerebellar plane. Just two more planes which are important. This is the most important and slightly difficult of all. This is the plane for the abdominal circumference. As you can see, here posteriorly here is the spine. On both sides are the ribs. Here we see the fundic bubble, the stomach bubble, and this is the intrahepatic part of the umbilical vein. This is the section you require to measure the abdominal circumference. There are two ways you can do it. From skin to skin, you measure it in an ellipse form, or you take two measurements. One is an antero-posterior diameter and one is a transverse abdominal diameter. Okay, and the machine calculates for you the abdominal circumference. Now, it is very important to measure an abdominal circumference correctly, because you're going to make all your diagnosis of FGRs and LGA on this particular circumference. It is measured on the outside of skin line. The section should be circular and not oval. Do not include kidneys in the section. Umbilical cord insertion should not be visible, because then you've gone down. You need to come up a little. the J should not extend. So this is the J. It should not extend all the way to the skin. It should stop here. So this is the perfect section for an abdominal circumference. Now coming to the last one is the femur length, relatively easy. Try to have it in a 45 degrees angle, and this 2 here is what you see as the acoustic shadow. This is the posterior acoustic shadow. What you measure is from the diaphysis end of one end to the other, and this is the femur length. Okay, amniotic fluid, I'll quickly run through in one slide. There are 2 ways of measuring it. One is a 4-quadrant method, where you take the sum of the deepest vertical pocket from each quadrant and you measure the total AFI. And another is a single vertical pool, which we are all coming towards now. So we are more inclined to do a single vertical pool, and we have defined cutoffs for poly and oligohydramnios. Now the last 2 slides, where I would just want to throw some light on the customized and population growth charts. And just there has been a lot of enthusiasm going on in the last decade about having to use customized and population-based growth charts. But this huge study by NICHD in 2018 has come up with a very, very large number of non-Hispanic, Hispanic, Asian and Pacific populations, and we see that they all beautifully overlap, and the only skewing happens towards term and post-dated fetuses, okay? So we are doing very well if the whole world uses the same standard growth charts, okay? It's very good to have population-based charts, but we know the practical problems. We don't have large numbers. Even if we do have population-based charts, we are unable to incorporate it into our softwares, and hence we may feel falsely that we are overdiagnosing FGR. But this study here, which is the largest so far, has actually proven that we are doing pretty well with one size fits all concept, and we can use the standard growth charts for all our growth scans. Okay, so this was actually an argument between the Baske and Beheshad group and Gardosi, and I would like to acknowledge Dr. Bijoy sir for his help for this. And just to summarize in the last line, customized growth charts do not have a statistically significant advantage over the routine standard one-size-fits-all growth charts. It is acceptable to use the standard routine growth charts and concentrate more on a comprehensive approach towards FGR diagnosis, which we would be seeing in the next 2 talks, rather than attempting to oversimplify the centile approach and growth chart customization. Okay, so free online charts, Barcelona Fetal Medicine Foundation, they are available free of cost. And with this, I leave you with the 2 stalwarts who shall take you ahead in this journey. What if there is no normalcy? Over to you, Dr. Vivek, sir.
Well, thank you, Pooja. That was really wonderful, nicely elucidated. Please remember that this was the key to all growth issues. Very well taken, and I'm for the sake of time, because we are running short of time, we know this huge agenda, and all of us have to break for dinners also. So let's go straight to the point and let us talk about the next step. Now that, either the fetus is appropriately aged and measured, or the fetus is smaller, but what is the role of Doppler? And this is what we are going to do in the next 20 minutes. But before that, let us just remember Christian Andreas Doppler. He's the man who told us that there's a value of Doppler, and slowly over the next 1 century, the application of Doppler came into for our fetal well-beings. So thanks to him, and the name of Doppler goes after him. We know that there's a lot of applications of Doppler in pregnancy, early pregnancy and things like that, and even in anomaly scans. But here we are talking about growth and the role of Doppler in growth. We also must remember that it is the reactive CT gene which largely excludes hypoxemia. Now I'm starting with this straight away. But a non-reactive CTG is associated with a wide range of pH values. So when our clinicians are going to rely on CTGs, there's already a chance that the pH values have already widely deranged. Only 50% of patients with an abnormal CTG have evidence of hypoxia acidosis on fetal blood sampling. CTG is likely to be reactive with the mildly hypoxic fetus and does not critically differentiate a fetal pH from being close to or far from 7.2. And that is what the pH we want in our fetuses, 7.2. So which means that CTG, well, yes, its applications are very much there, but to critically differentiate whether this fetus is really getting hypoxic, the CTG sometimes will fail to tell you the early hypoxias. Now we tackle the BPS head on. Now, as you see from this chart, it is the 7.2, and any drop in the fetal pH, that is hypoxias and acidosis, the fetal movements are going to get reduced. But please remember, look at the fetal pH at that time when the fetal movements are going to get reduced. It really drops down. So which means that by the time we keep waiting for the fetal movements to go down, that is the time when it might be too late for us to intervene, and so forth. So therefore, I beg your pardon, but yeah, okay. I think it's jumped a few slides, so I'll go back. Okay. And this was very important, which I wanted to show you. This one. Now, this is the scientific basis for the most sensitive parameters. On this screen, you can see that the fetal heart analysis on a fetal pH of 7.2, the reaction is when the fetal pH is really going to get fluctuated. Similarly, in BPS, when we see that the fetal body breathing movements are fine, even in a mild fluctuation of pH values. But look at the Dopplers here. All the Dopplers are super sensitive to even a mild fluctuation of fetal pH values. That is why the Dopplers have overtaken all of this as the single most reliable measurement or the indicator for fetal hypoxias. Now, a lot of you clinicians must be wondering, on one side, there's a risk of continuing intrauterine existence, and on the other side, there's a risk of prematurity. That is when you want to take the babies out. And to resolve this conundrum, it is that we are relying on a lot of physio practice guidelines, and they have come out in 2013. So we make this as a cornerstone and we move on from there. But the main issues on Doppler optimization, please remember, is the 2Ds first. So we need an appropriate plane. We need to have a zoom area of interest. We need to have the velocities and the wall filters which are set appropriately. We need the powers and the gain which is appropriate. We need the angle adjustments. We need the narrow color box. Please remember, let us not have a very big color box. Otherwise, it's going to make your machine work very hard. And if your machine is made to work very hard, the resolutions will drop. So please, whenever you put on Doppler, please have a smaller window so that the machine is able to take up and give you a good 2D images. Plus, it's going to give you the relevant color flow also. And of course, then the range gate positions, the gate size and the sweep speed. We are going to tackle all of that very, very quickly. Please remember, this is just, the time limitations are there for us. And that is why these issues are important. So now to get a Doppler, we need to get a good B mode image using anatomical landmarks. And these are issues which are extremely important because we don't want our umbilical artery to be insulated at a wrong end. We must optimize the B mode images. We must optimize the color Doppler images. We must know how to do that spectral Dopplers and the role of auto optimizations. We must measure the various spectral Doppler indices and of course report and interpret. That is again a very important thing. Now before we start, let us talk about the maternal positions. During Doppler studies, the mother should lie in a semi-recumbent position. Please remember that there's always a risk of developing supine hypotension in such patients, and then that could lead to problems such as cable compressions and things like that. So let's have the lady semi-recumbent with a slight lateral tilt. Also, when the fetal heart rate drops, the diastolic phase of the cardiac cycle is prolonged and the end diastolic frequency shift will decline. So if there's a slight transient bradycardia, do not, do the spectral Dopplers, do not interrogate, wait for the cardiac fetal heart to come back to normal and then go ahead and do your job. Now, fetal breathing also. During active fetal breathings, there are variations in the shape of the flow velocity waveforms from fetal vessels, and therefore Doppler examination should be conducted only during fetal apnea, which means that when the baby is not breathing or there's no fetal hiccups, or if the fetus is moving too much, please wait, let the fetus settle down, and then go ahead and do your interrogation of your spectral Dopplers. Also, blood viscosities also need to be remembered, and that could lead to increased peripheral resistance in case there is one. Now, often this is one question which is asked, which indices to use? Please remember the S upon D ratios, RIs, and the PI values. These are three well-known indices and they are highly correlated. But out of these three, PI shows a linear correlation with vascular resistance as opposed to both S upon D ratio and RI, which show a parabolic relation with increasing vascular resistance. And now additionally, PI does not approach infinity when there are absent or reversed diastolic values, which means that once there's a diastolic value which is absent or very, very less, the PIs will still go ahead and give us a number. So that is why PIs are the most commonly used indices now these days, and it is a good idea to throw S upon D ratios out of the window. So PIs and maybe RIs, if you still are insisting on RIs, they are good enough. Now, color box area, as I told you earlier, decreasing the color box area increases the color resolutions and also the frame rates. And please remember the frame rates we need are good ones because that is going to give us a good B mode images. Focus, yes, it moves automatically when the color box is moved, but then make sure that the focus is on the area which you want to show and see. Now, many times we see when the clinicians are doing their ultrasounds and the color Dopplers, we see that the vessels are bleeding all over. And this is generally due to low PRF values. And that is where the color aliasing is happening. And if we see this figure on the left of your screen, that is the low PRF values. So what you need to do is you need to slightly correct your PRF values so that the vessels are appropriately filled. But if you do it too much, that is too high PRFs, please remember the vessels will not fill up completely and you may get a wrong information. So therefore, a correct PRF is always necessary. Please also remember that when you are interrogating any vessel, there's enough gate width should be there to include the entire diameter of the vessel. For example, umbilical, uterine, or middle cerebral arteries. Now, if the Doppler gate is smaller, the entire wave pattern will not come. So you will probably see a dampened waveform, which may lead to misinterpretation of the Dopplers. Also, if you would see these two, now this is the same fetus and done at probably the same time. But what is the difference? On one, you might say that, okay, this is an absent end diastolic flow in the umbilical artery. And on the other side, this is a normal umbilical artery diastolic flow. Well, actually, both are normal. The only thing is that on the image on your left side, the wave filters are too high. So if that is happening, the wall filters, it is going to cut off the lower velocity of the waves. So you will see all dark near the baseline. For example, this one. So this is actually not a absent end diastolic flow. In fact, this is a normal flow, but just that the wall filters were too high here. And this is an appropriate wall filter. So please remember that once you do all this, please check your wall filters and please check that all the other issues are appropriately addressed before you go and do the spectral Dopplers. The sweep speed, very quickly, I'll tell you that this one, the image on your left side is a very, very low speed because there are too many waves which are getting crowded. And on the image on your right side, the sweep speed is too fast, which means that the waves are really traveling very fast and you can see only one or two waves in one frame. Please appropriate the rate or the sweep speed should be appropriate in which you can see 3, 4, or maybe 5 waveforms, which will give you a good assessment of the systolic and the diastolic phases, and that should be taken care of. Now, again, this is umbilical artery, and you see that if the fetus is breathing, this is the kind of waveforms that you'll get, and if the fetus is not breathing, you'll get a better waveform. So please wait. If the fetus is breathing, you need to wait a while. So now we go on to the very quickly to the various aspects of the Dopplers, and this is one which, of course, I've taken from my teacher, Dr. Ashok Khurana also. This is the blastula stage. And this is when it's invading the endometrium to implant itself. And these are the tiny vessels which are enlarging and forming. And this is angiogenic factors which are making these vessels enlarged. So this is the formation of uteroplacental circulation, which means that the spiral arteries are forming into uteroplacental vessels, which means that there's a lot of uncoiling, there's a lot of dilatation of these vessels happening. And what that happens is that more blood is able to flow through these spiral arteries and form the uteroplacental circulation. Now, these are the samples. You must have seen these figures before, but for the sake of making it, since this is the most important tissues, we must remember that this is the normal impedance flow in the first trimester, this is the normal impedance flow in the second trimester, and this is the normal impedance flow in the late second and the third trimester. Please remember that notching is no longer that important. Notching is normal in first and early second trimester. Uterine arteries on both sides to be interrogated. And it is the mean PI percentile to the gestational age, which is the single most important criteria. So uterine artery notching, not important anymore, but we will discuss more and we'll elaborate it more once the panel discussion is coming. And of course, we'll address all of those queries as well. So uterine artery Doppler, there's no critical endpoints for uterine artery indices. The pregnancy needs just further surveillance in case the PIs are increasing. Site, transabdominally, the probe is placed longitudinally in lower lateral quadrant of the abdomen, angled medially. Color flow mapping is used to identify the uterine arteries as they cross the external iliac arteries. So please remember, it is the crossing which is important. The sample volume is placed 1 centimeter downstream from this crossover point. So if you see the crossover, try to interrogate the vessel below the crossover point. But in a small proportion of cases, if the uterine artery branches before the intersection, the sample volume should be placed on the artery just before the uterine artery bifurcation. So the same process is repeated for the other side. But please also remember, with advancing gestational age, the uterus usually undergoes dextrorotation. Thus, the left uterine artery does not run as laterally as does the right. So please remember, you have to be very, very careful and identify the uterine artery as it crosses the external iliacs and the internal iliac, and we identify the crossing vessels. This is at the level of junction of the cervix and the uterine fundus. So we go laterally, we find out the junction of the cervix and the uterine fundus, and then we look for the crossing vessels. Similarly, for the first trimester, you know how important the first trimester uterine arteries these days have become, because that's a very, very reliable predictor for preeclampsia as well. Transabdominally, a mid-sagittal section of the uterus is obtained and cervical canal is identified. An empty maternal bladder is preferable. Please remember, the probe is then moved laterally until the paracervical vascular plexus is seen. Color Doppler is turned on and uterine artery identified. Measurements are taken at this point, and the same process is repeated on the other side as well. And please also remember that the patient has to be on dorsal lithotomy position and probe placed in anterior fornix, probe moved laterally to visualize paracervical plexus. And please also, one point of caution and very, very important, please avoid cervicovaginal arteries or the arcuate arteries or its branches. And how do we know this? We must remember that the velocity of the uterine artery should be over 50 centimeters per second. And if that is not happening, please remember to repeat again, look for a proper uterine artery, take your time, and then go ahead and interrogate the uterine arteries. Because sometimes the branches can be interrogated with a lower velocity and give you a false reading. PI, yes, preeclampsia in the first trimester is extremely important. We have to do both the sides, and percentile of the mean PI to the gestational age is the only reliable criteria. Please remember that the uterine artery notching is no longer important. So that is the uterine artery, and we know that the normal waveforms in the third trimester, the diastolic, the diastolic flow is going to increase. Moving on to the placenta. Now, these are two images of a good placenta and the placenta that has attenuated. So which means that it is the placenta which is attenuated is going to give us problems in the fetus. Now, this is the umbilical artery, which is now very, very important. And this image demonstrates color and pulse wave Dopplers used to evaluate the umbilical artery. The sample volume, for instance, is 0.5 to 1 millimeters. Insonation angle, again, is good. It is less than 30 degrees. We can talk about insonation angles when we are talking in the panel discussions also, and velocities should be appropriate. Now, approach and protocol for study of the umbilical artery. The Doppler gauge should be the same size as that of the vessel being interrogated. Please remember the size of the vessel matters, and we need to appropriately adjust the Doppler gates. We must place the gate in the center of the vessel, and the angle of insulation should be appropriate. Ideally less than 30 degrees, and if it is less than 30 degrees, you'll get even better spectral waveforms. It is always a good idea to study the umbilical cord in its entire length to rule out any abnormalities such as knot in the cord. Please remember, it is the knot in the cord which can be very, very tricky. And therefore, it is always good to move your transducer a bit, look at the whole length of the umbilical artery, and try to be careful about that. So these are again some charts which are taken from the net. This is the normal in the first trimester. This is the early second trimester and the third trimester. The difference is that the diastolic flow in the third trimester has increased, and that is what is normal. We expect that to happen. But look at the abnormal ones. This is where the diastolic flow is a little less. This is where the diastolic flow is really going down and the PI values are coming up. This is where the diastolic flow is 0, which means that it is absent end diastolic flows. And this is where the diastolic flow has gone below the baseline, which means that it is reversed end diastolic flows. We will talk about all of these situations once Dr. Chander Lulla takes it, and then we can take it in the panel discussions. But here on the images on your left side, please remember that the sweep speed and the PRF values are the ones which are as important in umbilical artery as anywhere else. So then it is the umbilical artery, and please remember that absent end diastolic flow is sufficient to warrant termination of pregnancy. A lot of my clinician colleagues also talk that doctor, should we terminate the pregnancy? You know, it's absent end diastolic flow. But I feel that absent end diastolic flow will warrant closer surveillance in most of the cases until unless there are some other factors. And of course, we will all discuss this in our panels as well. So it is the normal range and the critical endpoints. The abnormal indices indicate placental insufficiency, and this is the cutoff was 28 weeks according to Professor Kypros Nikolaidis, where he said that if it is a reversed end diastolic flow, we need to assess further, and if there's an absent end diastolic flow, at 28 weeks, we need to assess further, which means that we need to raise the red flags in these situations. Please remember, this is the velocity reject again, which was too high. That is why it was absent end diastolic flow, and we need to be appropriate and very, very careful. Now, most often, another issue is that where do you sample the umbilical artery and in the cord? Should we go in the fetal end, free loop, or the placental end? The measurement should be taken in a free cord loop for the sake of simplicity and consistency. But please remember, the fetus is liable to kick that fetal end, the free loop. So you have to be careful about that. And in multiple pregnancies or when comparing repeated measurements longitudinally, recordings from fixed site, that is either the fetal end or the placental end, may be more reliable. I, for one, in case there are multiple pregnancies, I generally go towards the insertion end, which means I'm sure that this umbilical cord belongs to this fetus. But please remember, there are different reference ranges according to site of interrogation, which means that if we go towards the fetal end, the indices are different because the velocity incidences, the velocity indices are different. So in a two-vessel cord at any gestational age, the diameter of the single umbilical artery is larger. So when there are two arteries, and the impedance will be lower. So please remember, if there's a single umbilical artery, the impedance will be lower. And in multiple pregnancies, there may be difficulty in assigning a cord loop to the specific fetus, and therefore we need to be very careful and be sure that we are interrogating the appropriate umbilical artery which belongs to that fetus. So these are the charts that we should always refer to, and PI more than 95th centile with reduced absent reversal of diastolic flow needs proper surveillance or action. And if for the first time umbilical artery PI is high in otherwise normally grown fetus, repeated tracing should be obtained or repeated after some time. Please remember, the umbilical artery showing you higher PI could be the early or the first indicator of the placenta that is failing. And it is the rising trend that is significant. And over there in this graph, this is what normally should happen. That is the PI value should normally drop. But here, as you see, this is the same fetus, and we've taken the umbilical artery Doppler tracings over a period of 1 or 2 weeks each. But we see a normal umbilical artery Doppler. This is the increased PI. That stage develops into absent end diastolic flows, and then the reversed end diastolic flows. So this is the stage that we need to look at. Now that is as far as the umbilical artery is concerned. Then we move on to the third most important issue is that what to do once we see that the umbilical artery is showing a higher PI. We go on to the MCA or the middle cerebellar artery Dopplers. But to go there, we need an axial section of the brain, which includes the thalami and the sphenoid bone wings. Color flow mapping should be used to identify the circle of Willis, and the proximal MCA should be selected. The pulse wave Doppler gauge should then be placed at the proximal third of the MCA, close to its origin in the internal carotid artery. And please remember, it is very important to take a proper circle of Willis, and the angle between the ultrasound beam and the direction of the blood flow should be kept as close as possible to 0 degrees. So if there's a good insonation, we'll get a very good Doppler, spectral Doppler tracings. Care should be taken to avoid any unnecessary pressure on the fetal head. At least 3 or fewer than 10 consecutive waveforms should be recorded. The peak systolic velocity and the PI usually calculated using auto-trace measurements, but then you can always go and do it manually as well. It's not going to matter really. Now, appropriate reference ranges should be used for interpretation, and the measurement technique should be same as that used to construct the reference ranges. Now, in this case, this is an excess probe pressure. See the image on your left side top, that's an excess probe pressure. The image on the top right side is the fetal breathing when you've taken it. And the image on your left side bottom is the inappropriate angle alignment. And the image on your right side bottom is the appropriate angle alignment. So angle alignment is also very, very important. And achieving the best angle is by probe movement skills. Please remember, we cannot be waiting for the fetus to move itself. We can move the probe and take a good angle, and we can therefore insonate. So Mca Normograms, yes, there are normograms. These are freely downloadable from charts, and we can compare them. Yes, the middle cerebral artery, and we must compare it and take out the percentiles. So Mca Abnormal Waveforms. Now this one was a normal one, but here you can see that the brain sparing has set in, and the brain sparing is the term that we use when the fetus is trying to redistribute the blood, which means that it's trying to send more blood to the fetal brain in cases of hypoxias, which also means that the PI values are going to go down and the diastolic flow is increasing. So once that is happening, then that is the term that we use as brain sparing. Also, please remember that once brain sparing in the fetus sets in, then we need to go to look at other parameters as to define when to terminate this pregnancy and what to do about this fetus. But also at the same time, please remember the brain sparing effect may be transient. Overstressed fetus can lose brain sparing effects. Loss of brain sparing effect may precede fetal death. So therefore, we cannot be waiting for the brain sparing effect to disappear. We just need to go and interrogate the other Dopplers and then make your decisions. The myth, the single value of low PI tells us about the onset of brain sparing fact, but the fact is that it is the serial studies which is more accurate to diagnose a brain sparing effect. The other major utility once we talk about middle cerebral artery is the fact that if there's a suspicion of isoimmunization, we should look at the peak systolic velocity. And this is the single most important non-invasive criteria with sensitivity reaching 100%. Now that is a very, very good way. 100% non-invasive technique, and if we refer to Murray's charts and other charts, we can know that yes, there is a fetal anemia, and that could be a result of isoimmunization. If there is 1.5 mom and rising, should alert us about the possibility of fetal anemias, and therefore so and so forth. The other parameters that we can look for is the tricuspid regurgitation, which may precede hydrops and ascites, and if the fetus has got tricuspid regurgitation, we should suspect anemia even if the MCA is normal. I thank Dr. Chander for this slide, but we are going to put this slide, and Dr. Chander is going to tell us about the other cardiac remodelings and the neural remodeling that can happen in FGR babies, and that is something that we are really looking to now. A lot of research is happening as far as cardiac remodeling is concerned, and we are going to talk a little bit about this, although I know that it can take hours and hours to discuss all of this. So to say that it is the umbilical artery, yes, 30%. If the umbilical function is just about, the placental function is just about 30%, we can see the changes in the umbilical artery. But apart from the umbilical artery, it is the middle cerebral artery which is going to tell us whether the oxygenation is normal or there's a mild vasodilatation or the PI values have really fallen down. So what is cerebroplacental ratio? We must remember that the perfect indices of umbilical artery and the middle cerebral artery may be normal. So it could be higher than 5th centile and could be lower than 95th centile. But yet PI value, middle cerebral artery may be falling and the PI in the umbilical artery may be rising. So therefore, that is the ratio of the PI values of the middle cerebral artery divided by the PI values of the umbilical artery. And that is what is going to give us the cerebroplacental ratio. And cerebroplacental ratio is the one ratio that is much more sensitive than umbilical artery alone, or of course the middle cerebral artery. There's been a lot of papers on this, and it's been if you go and look for cerebroplacental ratio, there are loads and loads of papers which are favoring now, like this one, for example. This suggests that cerebroplacental ratio calculated as a simple ratio between MCA is better related to placental insufficiency. This is Baski group saying this, and this is the Barcelona group has also said that the cerebroplacental ratio is significantly associated with increased risk of stillbirths and perinatal losses. So therefore, the cerebroplacental ratio has to be included in all the Doppler studies that we do in a fetus. And for example, in this is one case where we see that the cerebroplacental ratio has actually dropped below 1. Please remember the normal range is more than 1.05, and if it is less than 1, then we need to get worried. So these are some other papers. For the sake of time, I'm not going much into detail. We can take all of this once we are doing the panels. And of course, just to remember that cerebroplacental ratio is now much more sensitive than umbilical artery and the middle cerebral artery. These are the sensitivities and normal and end critical points. Let us go to the panel once we discuss all of this. So moving on to the next very, very important one, ductus venosus, which connects the intra-abdominal portion of the umbilical vein to the left portion of IVC just below the diaphragm. The vessel is identified by visualizing this connection by color flow mapping, which demonstrates a high velocity at the narrow entrance, and therefore, it's going to give us a lot of information. And what kind of information this gives is that it is going to tell us whether the PI values are rising or the PI values have really fallen. We do look at the A waves, but we don't wait for the reversal of the A waves anytime now to describe that the ductus venosus is abnormal. So it is the rising PI, more than 95th PI for the gestational age, when we say that, okay, ductus venosus is getting abnormal. Please remember the waveform is usually triphasic and the velocities are relatively high. So therefore we need to appropriately set our machines accordingly. Also, the role of ductus venosus in the first trimester is equally important. We must remember that 80% of trisomy 21 fetus will have abnormal ductus venosus. And that is the first trimester ductus venosus, which is very, very important to rule out trisomies and some other cardiac defects and things like that. So the technique of ductus venosus, yes, we have to switch on the color Doppler. We have to, please remember, narrow the window. We can either take it on a sagittal section or a transverse section, look at the maximum aliasing, look at the area just below the diaphragm, the area of maximum aliasing where the umbilical vein is coming and it is diverting blood to the IVC. And that is, if we interrogate it, please remember the color Doppler gate should be small, and there should be appropriate wall filters which should be low, because so that there are surrounding vessels which might interfere. Like this one, in this one there was some waveforms below the baseline. So we were thinking that whether actually this is a reversal of the A waves or it is just interference. But once we at a high level, then we realize that yes, truly the A wave has reversed here, and it is not just the interference. So please do not hesitate to change these modalities to see that whether the ductus venosus is correct or not. Also remember that the ductus venosus is modulated by the ductus venosus diameter, increased hematocrits, and portal venous resistance, and also some other factors such as prostaglandins, which our clinicians are so fond of giving, that can also lead to abnormal ductus venosus. So this is normal and that is abnormal. So please do not wait for the A wave reversals. If the PI values are rising, that is what we need to check. Now a word about umbilical vein. Pulsatile umbilical vein is a sign of cardiac decompensation. This will increase, this indicates severe acidemias, asphyxias, and we generally don't see it now these days because we tend to terminate the pregnancies much before the umbilical vein gets abnormal. So a word about the aortic isthmus. We know that the aortic arch has three branches: the brachiocephalic trunk, left common carotid, and the left subclavian. And this is a narrowing, a small little narrowing after these three branches come out, and we place a spectral Doppler at this narrowing, and we take a spectral Doppler and we see that it is the aortic isthmus. This is the forward flow, and please remember this is the reverse flow. So it is the antegrade to retrograde flow that we need to check. And if that is happening, then that is a bad predictor for that pregnancy. Why? We can discuss it later. Is that if the fetus, there's a brain sparing effect happening and the fetus is drawing a lot of blood to its brain, it can take out the blood which is not very rich in oxygen, and that is not very good in metabolites. And if that goes into the fetal brain, that will cause neurodevelopmental problems later on. These are several studies, and for the sake of time, I'm going to skip them because we need a lot of, the agenda before us. So the carry-home message is we need to know why we are conducting a Doppler. We need to know which vessel and where to interrogate. The technique has to be followed properly. We must also be aware of the pitfalls and repeat the readings. Then we should be able to interpret these findings for optimal fetal well-being. We must incorporate the percentiles. Please remember, it is the percentiles for the gestational age for each and every Doppler reading. Must incorporate cerebroplacental ratio, as this is the most sensitive parameter. Aortic isthmus studies are helpful in difficult delivery decisions. I thank you all for a very patient hearing. And over to you, Dr. Chander sir, for your presentation on FGR versus SGA.
You're on mute, doctor.
Yes.
Now, am I audible?
Yes.
Am I audible?
Yes,
yes,
doctor.
you
Am I
are
audible now? Okay.
Yes, you
so
are
as we know that, when we're dealing with fetal growth restriction, the most challenging problems are definition and detection. Now, all this while, Pooja and Vivek have done a wonderful job in laying down the concepts. And here you can see that we've always been calling it IUGR or FGR, but with the passage of time, since the last 30 years that we have been doing ultrasound and Doppler, we have now realized that the new definition of IUGR or FGR should be failure to reach growth potential. So it should actually be FRGP, because every baby has its growth potential, and if the baby does not reach its potential, that means it is not doing well. So traditionally, of course, we used to take FGR as a surrogate for SGA, but now we know that this is not only an anatomical problem, this is a functional disorder rather than an anatomical disorder, and we'll discuss why is it so. The other issue is that what are the reasons why the baby does not reach an actual growth potential? It could be infection, it could be a constitutionally, racially small baby, and we are comparing it with larger growth babies. It could be genetics, of which we have already taken a lecture. It could be hormonal situations, or finally, as we truly call a growth restricted fetus due to a placental insufficiency because of lack of proper trophoblastic invasion and lack of villi formation, as you can see in this wonderful cast that has been shown here of deficits of chorionic villi compared to a normal placenta. So the first step in management is diagnosis. You have to diagnose FGR, and that is the first step in management. So does size matter? Because a lot of people are in the fashion of saying it's not size alone. Of course, size matters. It matters, but size is not alone. So I have made this acronym size, small for gestational age, average for gestational age, and Doppler. So all these three factors put together makes a diagnosis of FGR, or as we would call it. So there is a small size baby, it can be FGRs. If there is a normal size baby and if there is a drop in growth velocity, but it is yet within the 10th and 50th centile, then also it can be FGR. And of course, if there is poor Doppler in any of these situations, that is FGR. So the first point of beginning of management is to detect a small baby. And we know why that is important, because the moment you have detected a small baby, you have reduced the perinatal mortality by 50%. So this is, if you see the stillbirth rate per thousand, detected IUGR has almost half the mortality rate of non-detected IUGR. So if you don't detect a small baby, that is the first misstep that you could be doing. So the moment you have a baby that is not growing according to what it is expected to grow, and it is smaller, that is the first step, and it may be a small for gestational age baby, and that would mean that it is below the 10th, 5th, or 3rd centile. Generally, we take a 10th centile, but there has been confusion in different centers. Some people take 3rd centile, some people take 5th centile. So the moment the baby is below the 10th centile, we call it a small baby. A large percentage of these could be constitutionally small, and therefore these are at lower risk of poor perinatal outcome. And that is important. If a baby is at low risk of poor perinatal outcome, we are not worried, and therefore it could be a small for gestational age. When does the red flag come in? When the fetus is not meeting its growth potential. That means it is below the 5th centile or below the 3rd centile, and of course we use the Delphi consensus definitions, which we'll talk about. Or also if the baby is averagely gestational age, that means normal sized, that is, it is above the 10th centile and it is falling in centiles, and we'll talk about that. So these babies are of course at increased risk of adverse outcome, and therefore this is what we are really concerned with, and that is what we call as fetal growth restriction. Traditionally, there can be serum biomarkers can be used for prediction, but these are used incidentally as and when we do the dual marker. If you have a low PAPE, or if you do a quadruple marker, and if you have a low AFP, and they are not conclusively proven to help in the management. What we really rely on, as Pooja said, is sequential ultrasound measurements focusing on declining or growth or crossing growth centiles. And then, of course, the most important part, as Vivek said, is the Doppler. That is essentially the umbilical artery, fetal middle cerebral artery, and the uterine artery, and the venous Dopplers also. So here we have a fetus which started on the 50th centile, but this lady is 150 centimeters in height. And if you can see, then subsequently she has dropped, but she is growing on the 5th centile, and the Doppler is normal. So here I would consider this as a small for gestational age, and there is no Doppler alteration. The growth is interval growth is good. We're not worried. This baby may not have a poor perinatal outcome. At this point of time, I will just put in perspective what Vivek just spoke about in one collage image about what's happening in the pathophysiology of FGR. And we know that when there is a problem with the perfusion from the placental side, that is the uterine artery, is responsible for supplying nutrients to the placenta from the maternal side. And then this blood goes into the umbilical vein and carries the oxygen to the fetus. And then it returns via the umbilical artery. So we have two components of the circulation in the placenta. One is the uterine artery, which perfuses the placenta, and one is the fetal vessels, that is the umbilical artery, which perfuses the placenta. And if anything goes wrong in the placenta, this can be reflected in both these vessels. And then we have oxygen diffusing via the umbilical vein into the fetus and straight into the vital circulations, the coronaries, the adrenals, and the cerebral circulation. So we have perfusion at one side and diffusion in the placenta of all the vital gases and nutrients going to the fetus. And as Vivek said, the cerebroplacental ratio is a very, very good marker and very sensitive marker for picking up a poor diffusion effect into the fetus, and it can pick up this poor diffusion much before this middle cerebral artery. So what we do, of course, is we do the cerebral artery and the umbilical artery, and then we do take the PI of the middle cerebral artery above the umbilical artery, and this is very, very sensitive for looking at the diffusion problems in the fetus. The middle cerebral artery is very specific. If you've got high diastolic flow, you know there is head sparing, as he just said. So how FGR progresses is determined by when it starts. Does it start early or does it start late? And how severe it is at the start. That means how bad is the umbilical artery abnormality at onset. So these are the two parameters which dictate of how this baby is going to perform. And it has been seen in studies of stillbirth that there are two areas where stillbirth is more common, that is before 30 weeks and then after 35 weeks. So these are two phenotypic groups where we will focus upon. Now, when you look at the Dopplers, as he just said, you will have a normal Doppler with good diastolic flow. With increasing placental resistance, you may see increased PI, absent end diastolic flow, reversed end diastolic flow. And this is a reflection of the perfusion from the fetal side, depending on the placental damage, that is the placental insufficiency. Now, the earliest sign that you start seeing umbilical artery changes is when the placenta is deficient by more than 30%. So till that time, the placenta is about 30% deficient in chorionic villi, you may see normal umbilical artery flow. And these babies, although having poor blood supply, may not present as FGR in the early part of pregnancy. And therefore, they can present in the late part of pregnancy as FGR when the demand of the fetus increases, and this group then manifests as late FGR. Whereas as the placental insufficiency is higher, that is from 50 to 70%, you will start seeing absent and reversed end diastolic flow, and then this is a marker of acidemia, and because the placental insufficiency is so high, these babies manifest early before 32 weeks. That's the cutoff, usually at 32 weeks. And that is what we call as early FGR. Basically, it just tells us that the FGR is very severe and the placental insufficiency is very severe. And that's why these two groups are from the Spanish group that we have very well elucidated what we call as early FGR and late FGR. In early FGR, as I said earlier, we have severe placental disease. We see a lot of abnormal Dopplers. The fetus is hypoxic and there is cardiovascular adaptation. The fetus is, however, immature because it is before 32 weeks, and therefore we have to wait for the fetus to become mature and then deliver. So there is a balancing act which Vivek was talking about. So there can be a high motility and morbidity in this situation. More importantly, what we were not seeing till about 5 years till now was late FGR. This concept was not very clear. This is a more common FGR and it can be missed because here the placental disease is mild. It doesn't present early. Till 32 weeks, everything is going well, and then you think that the pregnancy is going well, and then you don't monitor. And then suddenly, if there is hypoxia and the fetal demand is high, the fetus is not very tolerant because this is a mature fetus. It's not very tolerant to hypoxia, and then you have a higher mortality. So the first part of FGR is a nutritional problem. I'm sure in this COVID era, you have seen that you eat in, not so frequently because you don't need it as much. You're not very active. So you can do away with a lot of food for some time. You can starve yourself for some time. And this late IUGR is a sudden oxygenation problem. You cannot do without oxygen even for a few minutes, and therefore there is instantaneous death that we see as an unexplained stillbirth. So keeping these two phenotypes in mind, early and late late IUGR, we had the Delphi consensus identifying which parameters can be responsible in the early FGR and which parameters are responsible and can be visualized in late FGR. So when we are talking about early FGR, we essentially talk about the fetal weight or the abdomen circumference, which is less than the third centile, or if there is absent end diastolic flow as an independent marker. Also, if the fetal weight is between the 10th and the 3rd centile, we have to combine it with Doppler. So if you have increased uterine artery resistance beyond the 95th centile or increased umbilical artery resistance above the 95th centile, we call it early IUGR before 32 weeks. So as I said, IUGR now or FGR or failure to reach growth potential is an functional disorder. It's no longer size alone. It is size plus Doppler, which tells us about the adaptability and the poor nutrition the fetus is getting. After 32 weeks, any fetus which is less than the 3rd centile, we of course start getting worried, and this is late FGR, even if it is just an independent marker. Or at least two of the following, that is, even if the fetus is between the 3rd and the 10th centile, or if the fetus is crossing 2 centiles, that is 2 quartiles, that means there is a 50% drop at least in the fetal growth, then that is again what we consider as FGR and of course Doppler parameters. So two of these parameters to be there. And if here comes the important role of CPR. CPR, as we said, is a very, very sensitive marker. And when we are dealing with a fetus above 32 weeks, we need sensitive markers because we want to pick this up early, monitor it very closely, and deliver, because these fetuses are mature. They can survive even if they deliver them. And of course, umbilical artery PI above the 95th centile is also one of the sensitive markers at this stage. Of course, umbilical artery can be normal in late FGR, but if it is above the 95th centile, then we know that this is an abnormal marker. Everything put together will be integrated in as we go together in looking at the stage-based management. Now, the second step of management, of course, is timing of delivery, when to get this fetus out. And it's like we said earlier, it's a balancing act. You have to balance the fetal risk of how much time the fetal can stay inside and not die inside, vis-a-vis a neonatal risk where we shouldn't be giving a very premature fetus which has risk of respiratory distress, necrotizing enterocolitis, etc. So we have to have a balancing act, and this can be seen from this graph that if you have a IUGR fetus, the mortality is very high, as shown in red, in preterm fetuses compared to an averagely gestational aged fetus. So it's very important that we deliver at the appropriate time. And the best NICU, of course, is the mother's womb, and you can see from Ahmed Bashat's chart, before 28 weeks, if the fetus every day gains about 2% survival by staying inside, and after 28 weeks, 1% survival improves every day by staying inside. And similarly, also the morbidity. So very, very important that we do not remove these babies as much as soon as possible. Now, this is a 154 centimeters, 30-year-old lady with increased impedance in the umbilical artery. The cerebral circulation is normal, you can see here. But you see what is happening here. The fetal growth is dropping. It is come from the 50th centile to about the 5th centile and below the 5th centile. So this becomes significant because the CP ratio here will be increased. Similarly here, this is a late FGR. It was growing along the 5th centile and then suddenly has dropped below the 5th centile. And you can see there is the umbilical artery is above the 95th centile. So a late FGR in these two situations. Now, role of color Doppler is very, very important. I told you the third role is Doppler. And you can see that over the years, just by looking at absent and reversed end diastolic flow, we have prevented perinatal mortality by almost 50%. And this is what Vivek just showed in his lovely talk. 1994 is when we first published our paper on the role of color Doppler in high-risk pregnancy. And even at that stage, we looked at very basic parameters, and we could see that as the Doppler was abnormal, there was high risk of mortality. This was a very, very basic paper. Subsequently, we produced a lot of papers, but you can see the cascade of events as Doppler shows us the pathology when FGR progresses. So as the placental disease increases, you will have increased resistance in the uterine artery and in the umbilical artery, as we spoke about, the perfusion defect in the placenta, and this causes a growth deficit. And then the fetus centralizes, the fetus pushes blood to the head and via the middle cerebral artery, via the aortic isthmus, and this is called the compensated stage of hypoxia. Then we have a decompensated stage, because if you have worsening of the placental disease, the fetus can no longer compensate, and then you have cardiac ischemia and diastolic failure, and the ductus venosus starts showing us changes. And finally, there is serious injury and death, and only before the pre-terminal stage we start seeing CCTG changes, and therefore the ductus venosus is really an important marker. Of course, if you have CCTG along with it, it is also a good combination. So this is the centralization phenomena. As the umbilical artery resistance increases, the cerebral circulation diastolic flow increases. Individually, both these parameters are not as sensitive as I told you earlier, the CP ratio, and of course the end point is a reversal of the A wave. So CP ratio is very, very important, and as Vivek showed you, if it falls less than 1, that is below the 5th centile, we know the fetus is getting into trouble, and therefore as the Doppler worsens, you will have worsening of the biophysical profile, and he spoke to you about the pH, so I'm not going to repeat it. Now, this is a very, very important slide when we're talking about the second step of management, that is, how often should you interrogate the fetus? Very, very important. So if you have elevated umbilical artery, every 2 weeks, you should interrogate the fetus. If you have absent end diastolic flow or brain sparing, you increase the frequency to twice weekly. If you have reversal of flow, depending, of course, on the gestational age, if you have early IUGR, then you're waiting for neonatal maturity, then you interrogate thrice weekly unless your neonatologist says you can intervene and he needs the fetus at a better stage. What's most important is this paper, which was published, which said that any gestational age, any fetus which is small will do better if it comes out by at least 37 to 38 weeks. Otherwise, you increase the risk of stillbirth. So the moment you have a significantly small baby, you must target that your delivery should happen by 37 to 38 weeks. Now, when we are talking about early FGR, the truffle study has been most useful as the end point of when to deliver the babies. So the three criteria that have been used in the truffle study is the CCTG, which a lot of us do not have, but if you see variations from 29 weeks onwards, then we would consider it as a delivery criteria. Or if you have increased PI in the ductus venosus, then again that can be a delivery criteria. And of course, if you have reversal of A wave. So if you have a fetus which is less than 10 centile and you have abnormal umbilical artery, you immediately look at the venous Doppler to guide us when to deliver. And these are the three endpoints. And if you see, if you have a fetus greater than 26 weeks and less than 30 weeks, then of course reversal is the endpoint and you should deliver. You should have some rescue criteria. And of course, if the ductus venosus is normal, but if you have a fetus above 30 weeks with reverse end diastolic flow, you do not wait for the ductus venosus and you deliver this fetus. If you have a fetus which has reached beyond 32 weeks, then you even take absent end diastolic flow as the rescue criteria. But what's most important is the truffle criteria told us is that If you use CCTG alone, the survival is 85%. If you use ductus venosus increased PI, you've got a survival of 90%. You can use it in combination with CCTG. And if you've got ductus venosus reversal, you wait till then you have an improved survival of about 95%. So this is very, very important and allowed us to get the endpoints of when you should monitor before 30 weeks. After 30 weeks, as I said, you deliver the baby if you've got a reversed end diastolic flow in the ductus venosus. For late onset FGR that starts after 32 weeks, as we have been talking, the placenta may not be as diseased and so it could be less than 30%, and therefore umbilical artery, which is shaded in blue, dark blue here, may not show increased resistance, and that's why it has been missed. And this is well understood from Figueroa's and Gratakos's hypothesis that in the early part of IUGR, it is both a perfusion and a diffusion defect. This is because of occlusion of the villi or less number of villi or posicity of the villi. In the later part, that is after 32 weeks, it is the villi are there. They are edematous, they are immature, and if you have a sudden drop of oxygen and if the fetus demand is high, then these fetuses cannot survive. And so it is a diffusion defect, and the cerebroplacental ratio is an all-encompassing factor which can be used in both, but essentially better in the late FGR. So in late FGR, you can have changes which could be in the form of uterine artery Doppler, which could be above the 95th centile. By itself, if the fetus is less than third centile weight, you can see from this chart here that if you have a fetus which is less than third centile shaded in blue, then it is a very high mortality rate. And so just if the fetus is less than third centile, again, this indicates that this is, if the fetus is small, that this is a fetus at risk for fetal distress and neonatal acidosis. And of course, the CP ratio if it is falling below the fifth centile. So you can use a combination of all three, or each individually also is an independent predictor. And how do we monitor? We do a Doppler every 2 weeks. If everything is normal, you continue every 2 weeks. Any one parameter that is abnormal, you switch to 1 week. And then, of course, we rely a lot on the CP ratio. If the CP ratio is falling below the fifth centile, that can be an endpoint. We don't wait for an absent end diastolic flow or a reversed end diastolic flow. But unfortunately, if the fetus presents to you like this, then of course you don't wait for anything else. You just deliver. We don't rely on ductus venosus at this stage. So this is a fetus growing on the 10th centile. It was earlier on the 5th centile, and you can see suddenly here the PI of the umbilical artery is increasing, the PI of the middle cerebral artery is decreasing, and we have a CP ratio less than 1.61. It is below the 5th centile. And of course, there are other changes in the MPI and cardiac changes. I won't talk about them now. So late onset IUGR is basically an abnormal perfusion, and we need to tackle it. Now, finally, coming to stage-based management of FGR. Putting all these criteria together very intelligently, the Spanish group put all these criteria together, and we got this wonderful method of management, what we call as a stage-based management. So in stage 1, of course, it is mild disease, mild placental disease, where the fetal weight may be below the 5th centile, CP ratio is below the 5th centile, umbilical artery is above the 95th centile, middle cerebral artery. So all the Doppler changes are showing abnormality, but this is mild placental insufficiency. We do a weekly Doppler and we wait till 37 weeks and then deliver this fetus. So you have seen that there could be Doppler changes independently with a small baby. You then move on to stage 2, and what really decides is Doppler here. So Doppler becomes the important tool for changing your staging. So the moment you have absent end diastolic flow, you immediately move on to stage 2. Or if you have reversed aortic isthmus flow, you immediately move on to stage 2. And you then intensify your monitoring bi-weekly. So you twice weekly, as I told you earlier, moment you have absent end diastolic flow, twice weekly. reversed end diastolic flow thrice weekly, once in 2 days. And here your endpoint should not be more than 34 weeks, and you can deliver after 34 weeks, because then the fetus is mature, and your risk is high if you continue beyond that. Of course, you can use your ductus venosus at this stage. Stage 3, there is fetal acidosis suspicion because you've got reversed end diastolic flow, and generally in both these stages we start getting a little worried, especially the obstetrician wants to remove the baby, and we know they have justifications. The babies sometimes don't do well. There is redistribution. Aortic isthmus shows redistribution, and we know that there are some papers which suggest that neurodevelopmental outcome is not good. So here again, the ductus venosus, as in the truffle study, is above the 95th centile. Intense monitoring, and we should not go beyond 30 weeks. We deliver at 30 weeks if this is worsening, as you can see here. And of course, if you have stage 4, where there is the third criteria of the truffle study is the ductus venosus A wave reversal, and that needs intense monitoring. But if you are beyond 26 weeks, we would suggest delivery. So essentially, stage 2, stage 3, stage 4 is what you would be looking at in early FGR. If there is mild insufficiency, as we saw earlier, then this is what you would essentially be seeing in late FGR, where you would see any one parameter that is abnormal. You would do weekly monitoring and deliver as soon as possible. And this is all shown graphically here. It's very, very similar to what I just spoke. So I think you can visually imagine. What's important is in the first stage, everything is just mild. Your CP ratio is below the 5th centile. In stage 2, important change is happening is absent end diastolic flow and early reversal in the aortic isthmus. Stage 3, PI, ductus venosus, is increased, and more importantly, you have reversed end diastolic flow. Stage 4, of course, we would not wait for beyond 36 weeks. You can wait for only if you are before 26 weeks or before 500 grams, because then in any case the outcome is not good. And in the truffle study, it was suggested that a fetus should be at least 500 grams to begin with. And this is also put in an algorithm. I won't go through this. It's essentially what I just told you. This can all be put in a computer algorithm, and if you just go onto the Barcelona site, you put all these criteria together, and you will get the stage, and it will tell you whether this is late FGR, and it will also tell you whether to deliver or not. It will give you the percentiles, and this is what we generally use. It's very, very useful. Why this stage-based management? Because it allows comparison of data for IUGR fetuses if two groups, like if the fetus has moved from one center to the other, so it at least you know it was stage 1 earlier. It's easy to understand rather than looking at each individual parameters, and it also tells us the exact time for delivery, and that is what I told you earlier. The second stage of management is to know when to deliver these fetuses. Now, all this is fine, as was going fine, until we realized that sometimes even a normal size fetus may not do well and may suddenly become hypoxic. And that is because a large percentage of IUFDs that we saw in the 3rd trimester were normal size babies, or as we call them, average size babies. Even cerebral palsy, the morbidity that we see sometimes, these fetuses can be larger or normal in size. And this was a landmark paper by Asma Khalili, which said that occult placental failure may also occur in average gestational age fetuses. And this is what we spoke about earlier. Mild placental insufficiency, not manifesting till 32 weeks, the fetal demand increases, and suddenly this fetus becomes hypoxic and does not do well. So this is a fetus, as you can see here, was showing a normal umbilical artery, middle cerebral artery, uterine artery Doppler, well-sized fetus, 36 weeks IVF pregnancy, and then the ductus venosus also normal. 37 weeks, exactly 1 week later. This was a very, very precious pregnancy IVF, so we decided to monitor it 1 week later, 37 weeks. Our uterine artery Doppler is normal, and look at the umbilical artery. The PI suddenly drops. MCA suddenly shows Absent diastolic flow here, that means cerebral edema. And look at the ductus venosus. Absolutely bizarre. I was scared to see this ductus venosus. In 1 week's time, and the normal Leica, you can see absolutely normal looking placenta. So this is deceptive. And it is really scary, but fortunately we could salvage the baby. Another fetus here grows well till about 36 weeks, normal Leica, normal growth on the 50th centile, and good amount of diastolic flow in the umbilical artery, increased cerebral circulation, and look at the ductus venosus, high PI in the ductus venosus. So what I'm trying to show is that when we are monitoring these fetuses at a later stage, at 36 weeks, you need to do Doppler, because sometimes at 36 weeks, you may not get a good picture from just the anatomical parameters. And therefore, as I said earlier, FGR is not size alone, it is size plus Doppler. So it is a functional problem rather than an anatomical problem alone. And then, of course, we have a lot of pros and cons, and now Kipros has published one more paper, and there are other papers which tells us that CP ratio may not be as beneficial as we thought it to be. Of course, the final word is not out, but it goes to show that we need to continuously evaluate these fetuses and do research. And therein comes the factor that we have not so far been looking at cardiac changes in FGR. I'm not going to talk about this because this is a whole another topic, but we look at the sphericity index, we look at cardiac remodeling, we look at the strain of the heart, we look at fractional area shortening, the left ventricular ejection fraction, and a lot of other parameters, but this can be seen at another date. And this is Gregory Vohr's landmark paper, which said that at the end of it all, if left ventricular ejection fraction and the left is poor, and if the left ventricle dilates, we are in for trouble. So this is something we need to look at even more aggressively in fetuses, in the late FGR fetuses. To put everything in perspective, if you want a very simplified flowchart, management of FGR, look for fetal malformations and aneuploidy AS, then of course we manage it accordingly. No malformations. If you have elevated umbilical artery indices, 2 weekly Doppler, and then look for other parameters, fetal compromise, consider delivery. If you've got absent end diastolic flow, if you are above 34 weeks, deliver. If you are between 28 and 34 weeks, you monitor and of course use ductus venosus Doppler and give steroids, just like the truffle criteria. And another very, very simplified method is, if you've got a small baby, everything is otherwise normal, monitor every 2 weeks and expectant management. Anything comes normal, monitor every 1 week and deliver at 37 weeks. I can't make it more simplified. So in conclusion, FGR is now a functional disorder. The first step in management is identification of FGR. Then you look at growth velocity. That's the next step. Then you look at what is this phenotypic type? Is it early or late? And definitely the definite role for fetal monitoring in the 3rd trimester, as I showed you. Doppler is central to diagnosis and management of FGR. It allows us not only to diagnose, but gives us the exact timing of intervention to avoid morbidity and mortality. Management is stage-based. As I said earlier, we use the truffle criteria for early IUGR, and in the late FGR, we use a combination of biometry, CPR, and uterine and artery Doppler. And if anything is going wrong, we monitor on a weekly basis and deliver at least by 36, 37 weeks. So I think that was my last slide, and Vivek, you can take on from here. We can go on to the panel. Vivek, I can't hear you. You're on mute.
Yeah, I'm okay. So now I think you can hear me?
Yes.
Yes, very, very clearly.
Yeah, am I audible?
Now
Yes,
so we are moving
Jimit,
on to
very,
the
very
panel.
audible.
Okay.
Now, this is thanks, Dr. Chander. That was really a wonderful thing. I know that this is very complex issue, and to deal with it in such a simplistic manner. You've tried your best, but we know the conundrums of growth and how to go about things. Now, for the sake of time, I think we are running short of time, and there's a huge amount of questions coming in from the viewers. And I hope that in our panel, a lot of them will be answered if they have not already been answered by the talks. And some of them, the interesting questions, we will take them one by one. And for the rest of them, I think it'd be a good idea if we reply to each one of them on this and post it either on our website or something. But anyway, I think for the sake of time, let us just take 2 or 3 case scenarios. We have more, but I think let us take that. And audience, at any time, please feel free to type in your query and send it across. We will try and answer it as soon as we get it. But I'm sure that a lot of you people will already have had your answers by this time. So we move on very quickly to the case. The first case is a 29-year-old primary gravida, presents at 30 weeks of gestation, but the fundal height is only 26 to 28 weeks. So please remember, it should have been 30 weeks, but it's 26 to 28 weeks. She's had a dating scan at 7 weeks where CRL was 8.9 millimeters. At that time, it was corresponding. She had an early morphological scan at 12 weeks, 5 days with a normorange nuchal translucency of 1.4. An ossified nasal bone, normal PI for gestational age in the ductus venosus, and there was no tricuspid regurgitation. The anatomy scan at this stage was normal. Uterine artery Doppler was normal. She had a normal anomaly scan at 19 weeks, 3 days, and the uterine artery Doppler, which was done at the anomaly scan time, was also normal. So now she comes, and on examination, she's relaxed, nourished, has gained 9 kgs, no pedal edema, her blood pressure is normal, ultrasound revealed no anomalies, there's a normal placental morphology, and amniotic fluid index is normal, cranial parameters correspond to the 5th centile, the AC and the femur length to the 10th centile. Now this is where the problem starts to come, and the estimated fetal weight was on 14th centile. Now, this is one of the very common scenarios in our clinical day-to-day practice. And so, therefore, my first question to Pooja is that, is this growth restriction? And if it is, what should be the next step?
So this doesn't fall into the definition of a growth restriction because the fetus is actually growing on the 14th centile. 14th centile. But as we see that the abdominal circumference and the femur length are slightly lagging behind, I would just not want to leave this fetus alone without further surveillance. And since all other parameters on today's ultrasound are normal, I would call her back in 2 weeks' time to reassess the interval growth, Dopplers, and the AFI. I would also like to look at the height of the lady and probably the build, which could affect the fetal weight.
Precisely, and this was a lot of questions are coming in from audience where they said that why is Dr. Chander and others talking about the patient's height? You see, that is one of the very important criteria, because a small parent is going to have a small child, and that is where it's important to look at the parents. And please remember, not all small children are pathologically small. So my next question to Dr. Chander: what is an ideal plan for the following up of this patient?
Yeah, I think as Pooja just said, because the mother is small, we are expecting a lower growth profile. Fetus is on the 14th centile, so it may be a good idea to first have a evaluation at after 2 weeks, and if it's showing good interval growth, then I would increase the interval growth from there on, keeping in mind the racially small mother. But if I see that the growth is dropping in 2 weeks, then I would aggressively monitor. But it does throw a red flag.
Definitely. What are the treatment options, Dr. Pooja, in this case?
So, sir, yet we don't have a problem as such, so we don't need treatment because this is fairly doing well. But yes, we could supplement some amino acids, good nutrition, hydration, etc. Not that it is of help. Just want to keep a close watch on the fetus, that's it.
Which means that sometimes you need to play to the sentiments of the patient and their, relatives who are coming and saying that, this is being treated by this doctor and there are very little medicine that she's written. I hope everything is okay, and situations like that. So that is some situation that we have to handle as well. So, Dr. Jimit, what are the clinicians? How should clinicians balance prematurity, the fetal biophysical variables, the Dopplers, the fetal weight, and how it's going, and all of that?
So our main objective is, yeah, can you hear me now?
Yes.
Hello?
Yes.
Yeah. So our main objective is to make sure that the perinatal outcome is very good. We want to make sure there is no fetal hypoxia which sets in later on, and hence strict surveillance is very, very important in this particular case. How do we survey the baby? So ideally, 2 weeks later, we would want to do a ultrasound with fetal Doppler studies. And what would we monitor? So we would monitor the fetal biometry. We would be looking at the amniotic fluid index. We would be looking at the uterine artery Dopplers. We would be looking at the Mca flows. We would be looking at the CPR ratio and the ductus venosus in the end.
Excellent. So, which means that the patient has come back and we've reevaluated after 2 weeks, and this now reveals a expected fetal weight at 10th centile now, down from 14th centile, but the Doppler is normal. Now, in this case of scenario, you make out your reports, and then my next question to Dr. Pooja, what next really?
There has been near optimal interval growth over the last 2 weeks, and the fetus still continues to grow on the 10th centile, which is reasonable. We know that this is a short statured mother and a slightly constitutionally small mother. So the 10th centile is probably due to the lower femur length as well as the abdominal circumference slightly on the lower side. I would still not worry and call her back in another 2 weeks since the Dopplers and AFI is normal. And in the meanwhile, I would tell her to keep a strict check on the fetal kick count. That's the easiest way that we could keep an indirect check on the fetus.
So till the time the patient comes back for a Doppler, you'll feel very safe if there's a nice kick count every day and all of the other criteria are met, like the fetal movements, the daily fetal movements and all of that. So re-evaluation at 34 weeks shows an expected fetal weight now at 3rd centile. So it's fallen from 14 to 10th to now 3rd, but the Doppler is still normal. So this kind of a scenario is that now this slide has come in, but then Dr. Chander, now the patient is really perplexed. Now you see, now she's going to get a very small baby. So now she goes to the best in the town and she goes to Dr. Chander. And now the question is that Dr. Chander, what to do now?
Okay, so as you saw here, there is a drop in the growth from the 14 to the 3rd centile. But is the Doppler normal yet?
The Dopplers are normal.
Yeah.
Yes.
Yeah, the Doppler is normal. So yet I wouldn't be very worried because the fetus is yet on the 3rd centile, mother is small. Most importantly, the Doppler is normal. We could be potentially dealing with two conditions. One is that it's just a small baby and it's with a normal Doppler, I'm not going to worry much. I'm going to call her again back after 2 weeks. At 36 weeks, we normally do an ultrasound and Doppler. The second scenario is that there is mild placental insufficiency, and that's why the Doppler umbilical artery is normal. So I would look at the CP ratio, call her back after 2 weeks, and then do the CP ratio again. And if the CP ratio is not good, I would then consider delivery at 36 weeks. But in all probability, if she's a small mother with normal Dopplers at 34 weeks, there's a good chance that she may be normal after 2 weeks. But you never know. Like I told you, sometimes surprises come up. And therefore, when we're talking FGR, you have to be, there is no, the cutoff of anything is arbitrary. Like between late and early IUGR or between normal and abnormal, everything is arbitrary till you show it's normal. So we have to wait and watch.
So now the patient is really edgy. Now she comes, instead of 36 weeks, she comes to your 35 weeks. And now again, the expected fetal weight is 3rd centile. So now my question to Jimit. Yeah. So Jimit, what next? Now this is a little bit of a teaser because we face these situations every day. Now the patient and her relatives are going to ask you that if my fetus is safe, doctor, and what should I do? So, but you've done your Dopplers and you've in your team are trying to counsel the patient. So what are you going to tell and what are you going to plan next?
So definitely, because there are no Doppler changes and there is no significant drop in the estimated fetal weight, I would reassure the patient and just explain to them that I would want to prolong the pregnancy a little more and pull it on up to 37 weeks if possible.
But when would you like to call her again?
So ideally, with the apprehension and the falling EFW, I would want to reassess her after 7 days.
After a week?
After a week.
So at 36 weeks now, the fetal weight is first centile only, and the cerebral percentile ratio is 1. So it's a little bit more than that. So Pooja, now you are under pressure. Now all these patients and their relatives have come on to you, and they say that you are the best, the person who can advise. So should we deliver really?
Sir, a lot of factors will now come to interplay to decide whether I should deliver this fetus right now or not. I'm an obstetrician, so I would also like to talk on that behalf. I don't want to lose a baby between 36 and 37 weeks just like that, because like Chander sir said, it could be an interplay of two factors. It could be an overall constitutionally small baby with an superimposed aspect of a fetal growth restriction. Although we say that the Dopplers are normal, we can see here that the cerebroplacental ratio has now dropped to 1.01. We are more comfortable with 1.05. And if I have good NICU facilities, I've given her steroids, I would not mind delivering her right now. And I wouldn't want to wait for that 1 to go down to 0.9 or 36 to go to 37 and then deliver her. So in my setup, in most places where we come from, NICU is well equipped to deal with babies who are less in weight but have reached a maturity of 36 weeks.
No, I would totally agree with Pooja. I just want to make a word that unless you have any other compelling reason not to deliver, you would consider delivery. As Pooja just said, the only problem at the late gestation is sometimes that you get the normally high diastolic flow in the middle cerebral artery at 36 weeks. So that just does confound matters a lot, and therefore Kipros's paper on less reliability of CP ratio alone. But here, of course, the fetal weight has dropped to the first centile, and both these factors put together need to be looked at very seriously.
Now that Dr. Pooja's decided that, okay, she's ready to deliver, now the complications come when their set of relatives visit somebody else, and somebody else tells them that, look, this is the expenditure, the baby will go to nurseries, why don't we wait for some more time? So now the patient and their relatives are going to come back to Dr. Pooja, and Dr. Pooja probably is right in saying that at 36 weeks she will like to deliver, but then the argument says that the cerebroplacental ratio is right now not below 1. So in that case, maybe, would you really, Dr. Pooja, consider that you can wait, okay, for a few more days? Or would you like to really pull it along for some more time?
Sir, unless there is really a compelling reason for me to continue for another week, I would just deliver her right now. We've lost babies suddenly after 36 weeks without a reason. And what is the point in admitting her and doing twice a day CTG and daily Dopplers and trying to pull her on? The advantage that I'm going to gain from pulling her on from 36 to 37 weeks is not much when I compare that I deliver her and the baby may not even need an NICU care.
But if you then pull out a lot of papers which go along and everybody says that, look, 37 weeks is a good time to deliver, and if the cerebroplacental ratio is still normal, you can still think of 37 weeks and all of that. Well, that is one school of thought, but then you have your point. So anyway, the patient decides to continue. And now the expected fetal weight and the CPR is now less than 1. So now I think since you were already thinking of delivering, I think all my panelists will agree that we need to deliver. So I think Dr. Chander, you have any word to add to this?
No, it's essentially very appropriate
so the lesson
to deliver, because although the final word on CPR is not out yet, and in the of the accuracy of CPR, but till that word is not out, we would rely on the fact that the CPR is falling and the fetal weight less, and fetus is already mature, so there's no sense, as Pooja said, to continue with the pregnancy.
And then the clinicians remain on tenterhooks, just like that. So This is the iatrogenic prematurities which can be avoided by an evidence-based algorithmic approach and clinical surveillance. So we quickly move on to case number 2. I'm sure that a lot of queries have been answered because we had a barrage of questions leading to the timing of deliveries and the role of CPR coming in from
Vivek,
our viewers.
I see that there are at least 100 questions. You'll need another webinar for the questions only, but go ahead, please.
So what we can do is we can, take these questions, we can write the answers, and we can either post it somewhere so that all the viewers can visit the website and they can get their answers. I'm sure a lot
I
of
suggest you have a webinar only for questions.
Okay, we can arrange for that. Right. So very quickly moving on to the next one. Now this is again a very important one. This is a 32-year-old primate which presents in the first trimester, 12 weeks, 4 days of gestation with the first episode of bleeding per vagina. You do the ultrasound and the CRL is 45 millimeters, a heart rate of 181 beats per minute, and the nuchal translucency is 2.7 millimeters, a nasal bone of 2.4 millimeters, a ductus venosus PI of 1.16, and there is no evidence of tricuspid regurgitation. No major anomaly is evident on the transabdominal study. Visualization is markedly limited by maternal abdominal adiposity. She has had an earlier transvaginal scan at 8 weeks that showed a CRL of 15 millimeters, and which was corresponding. So my first question again to Pooja is this growth restricted fetus, Pooja?
Yes, sir. This looks like a growth-restricted fetus, although there are no centiles or arbitrary limits to define growth restriction so early. But I saw that there was a transvaginal scan at 8 weeks, which corresponded very well. So 15 millimeters corresponds to 8 weeks. So there is no dating issue, I'm sure of. At 12 plus 4 weeks, I was expecting a CRL of around 65 millimeters,
65.
whereas it is just 45 millimeters. So lagging by 20 millimeters is almost 1.5 to 2 weeks of lag here, and I would be really serious about this lag.
So Dr. Chander, can FGR manifest so early? Now Dr. Pooja is really getting worried. So yeah, so FGR can manifest so early.
So any first trimester FGR, if your dating is correct, as is here, we definitely suspect an abnormality, a chromosomal abnormality. I saw that the heart rate was 181, NT was 2.7, which is above the 95th centile, and I think these were the two parameters, NT and fetal heart rate and low growth. So definitely we could suspect an early FGR, well, due to a chromosomal abnormality. But I would do a very good structural scan if there are any omphalocele or holoprosencephaly or anything like that, any other issues which can guide us.
Yeah, so inputs from Jimit. What are the usual causes of this pattern, Jimit?
So definitely we are seeing a severe early onset fetal growth restriction here. And hence the common thing that we want to rule out is, first thing is aneuploidy. Second thing is any genetic syndromes with anomalies. We would also want to rule out any infection and any major problem with the placenta. So these are the 4 things that we would want to rule out in this particular patient.
Dr. Chander, any clues so far from the information provided for this growth pattern?
Yeah, I've already said NT is 2.7, heart rate is 181.
True.
So straight away, I think this is a genetic problem. There's not a placental issue, no infection. This is clear-cut genetic. It could be.
So what would you like to do now that?
But first is a good structural scan. As fetal ultrasonologist first, you need to do very good anatomy scan. I think that's very important.
So since you are hinting at a good anatomy scan, you probably picked up the line that there was a maternal obesity and adiposity of the mother. So therefore, the transabdominal scan was not satisfactory.
So transvaginal, I suppose. Yeah.
So would you like to do a transvaginal? So that is the next step. Correct. So which means that due to maternal or adiposity, we should not hesitate in doing a transvaginal scan, especially if we are suspecting something. So any higher NT, any growth lag, we should look at the possibilities of a transvaginal scanning. So transvaginal scanning reveals this. And this is the fetus which is showing a holoprosencephaly.
You have gross changes.
Yeah.
Yeah, so it was the maternal adiposity which was not able to pick it up. So the transvaginal scan reveals a holoprosencephaly, dysmorphic faces, and echogenic kidneys. So now, Dr. Jimit, what do you really think? Uh, and this is, remember, the first trimester. So holoprosencephaly, and what would be the likely diagnosis?
So seeing the semi-lobar holoprosencephaly, dysmorphic face, and echogenic kidneys, uh, first thing we want to rule out is aneuploidy, and the first thing in that would be trisomy 13. So I would definitely want to go for an invasive procedure.
Yeah, a chorionic villus sampling without doubt would confirm the findings that have been explained here.
Absolutely wonderful. So CVS confirms trisomy 13 as suspected. So that is a question that we need to know, and what are the lessons that we learn from this is that a dating scan at 11 to 14 weeks may not be as accurate as a dating between 6 to 9 weeks. So there is one situation where the early FGR and then we go back to the 6 to 9 weeks. So there are situations, it's not a 100% rule that we need a 11 to 12 week scan as a golden set for dating. Sometimes you need to go to an earlier scan as well. Also, the transvaginal scan are excellent modalities to delineate anatomies, especially in the obese patients and especially when we are suspecting some abnormalities. And please remember, aneuploidies, anomalies, and infections are important causes for very early growth restrictions. So I don't really know, should we go on to the next or the next? If you would allow me, there's a paucity of time, so I'll switch on to something which is extremely important, and rather than that, we can go on straight to something which we really want to carry home. So we are going to take another FGR case. Please remember, if there's more time, we can discuss more cases, but this one is the one that has got a lot of carry home messages to all those who are watching. This is one case with 34-year-old second gravida with previous unexplained IUD at 38 weeks. So please remember, it's an IUD in the previous ultrasound, in the previous pregnancy. Now she comes to you at 33 weeks of gestation with a fundal height of 26 to 28 weeks. So you are already now, in a conundrum. She has had an unreliable NT scan at 12 weeks, 5 days with a normal range nuchal translucency of 1.4 millimeters. The usual parameters are like nasal bone assessment, ductus venosus, tricuspid were not done. The uterine artery Doppler was also not done. And this is not an infrequent thing. We see so many reports being done where all these parameters are simply ignored. The anatomy scan at this stage was reported normal. However, the patient went for an anomaly scan at 19 weeks, 3 days. That was reported normal. Uterine artery Doppler was normal in this scan. So now on examination, she's normotensive. There's no pedal edema. There's no albuminuria. Ultrasound revealed no anomalies. There's an amniotic fluid index, which is normal. The cranial parameters correspond to 10th centile. The abdominal parameter and femur length also to the 10th centile. So which means that the estimated fetal weight was generally around 10th centile or even less than that. So my question to Jimit, what is the ultrasound definition of fetal growth restriction? Now, a lot of our viewers have asked this question. What are the ultrasound definitions and what is the definition of fetal growth restriction? So this becomes a very, very important question, Jimit. So please tell us what are the ultrasound definitions that you think of. I know that there are many, many.
So reiterating everything that you all have discussed, the first thing that we would want to rule out is fetal growth restriction, and the first criteria that we would follow is the estimated fetal weight. So if the estimated fetal weight is less than 10th percentile, then I would look at one, the cerebroplacental ratio. If the cerebroplacental ratio is less than 5th percentile, or the uterine artery is more than 95th percentile, or the estimated fetal weight is less than 3 percentile. If any of these three criteria are met, I would label this fetal as fetal growth restriction. If the Dopplers are normal, then I would want to label this fetus as a small for gestational age fetus, wherein just the estimated fetal weight is 10th percentile with normal Doppler findings. One also has to consider that in this particular patient, there has been a declining or a crossing growth centile. wherein the baby has been growing, and it has been growing from the 80th percent and going down to 20th percentile. So whenever the growth lag is crossing 2 quartiles, again you would want to think towards fetal growth restriction, and such babies need to be monitored regularly.
Excellent. So I think there's a very important question with complex answers, not really one answer, because there's been a lot of things if you pull down the literature, but I'm sure that must have answered a lot of queries which are coming in from our viewers. And for others, we'll be happy to post all these answers to all these questions on our website also. And we will, of course, give the address of our website so that people can go and look at that. So, Dr. Pooja, what are the risks of prematurity? Now that you have a situation at hand, you have a situation that that patient has had an IUD in the previous pregnancy. So now the pressure is entirely on you. What are the risks of prematurity in case you decide that, okay, you're going in for early delivery?
So risks of prematurity are short-term and long-term ones. The short-term, in fact, gestational age specific could be as harsh as fetal death, neonatal death. So mortality is one of the very important risks of prematurity, especially extreme prematurity. The other short-term ones are respiratory distress, bronchopulmonary dysplasia, infection, sepsis, intraventricular hemorrhage, and the long-term ones are actually the more severe ones. So the fetuses survive due to good NICU, but they do not need a neurodevelopmentally normal life. So cognitive disorders and as bad as cerebral palsy could be the long-term disorders of prematurity.
So we need to balance when we suggest an iatrogenic delivery in fetal growth restriction. So all these things need to be taken into account when we really take this decision. So that is, on one side is the risk, and the other side is also a prematurity risk. So my next question to Dr. Chander, what are the critical Doppler parameters now that the patient has come to you for the final answers that when they should deliver? So what are the critical Doppler parameters in deciding when to deliver?
So essentially, we always do a multi-vessel Doppler and we look at all the parameters. Of course, we look at the umbilical artery. That's the first vessel we always look at. It gives us a clear picture. If the umbilical artery Doppler is normal, you know there is no immediate risk. And then we look at the MCA, look at the CP ratio. And if this was on the 10th centile, right? So if although it is crossing centiles and it is about 30 weeks, so I would look at the CP ratio, and if all the Dopplers are normal, then I would just wait and watch. But if there's anything abnormal in the Dopplers, I would increase my interval of monitoring, and delivery will be decided on the basis of how the changes in Doppler happen, or if the fetus is falling below the 3rd centile.
Yes, these are your
balance. Yeah, we would balance prematurity with in utero risks and then take a call. So it's always a balancing act.
Right. These are your slides which you wanted to have a word on. That is the cardiac status and the cardiac remodeling. Yeah. I wouldn't mind if you just spend and tell our viewers for 1 minute that what really is all this about, the MPIs, the tie indexes, and the annual peak velocities and things like that.
Yeah. So we have observed cardiac changes in FGR, and there are situations where you can see here the left ventricle is small and the right ventricle is dilated. Now we need to analyze the functioning of the heart. So sometimes even where this is already, you can see 34 weeks, 6 days. And if you have cardiac changes in the form of altered strain, that is, strain is the ability for the myocyte to contract and relax appropriately, or if there is fractional area shortening, that is, the area of the heart is shortening, is it appropriately contracting? Is the ejection fraction good? And then we look at a lot of functional parameters like the tie index, which tells us, gives us a global idea of systolic and diastolic function. There are lots and lot of parameters that we look into, and this is a new area but also we see that there is cardiac remodeling. So the heart becomes more globular, it becomes more wider in the horizontal axis, and this can impact on long-term cardiovascular development in the child in a long term. So these parameters put together, there are well-defined cutoffs now, there are well-defined criteria. And so the important message is that we have to look at the heart also very closely when we have an FGR fetus. But I cannot mention in just one sentence, but just to say that these are parameters that we need to be. We have definitely good criteria on Doppler. This is a research tool yet, and a lot will be coming out of this in the coming years.
Exactly, and this is what I wanted you to say. This is early days, and the equipment is not available everywhere. The expertise is not available everywhere, and there are certain early days, as you said. So we need to wait and watch that whether there's a real cardiac remodeling and how many actual FGR cases you can go ahead and do this. I know that there are situations where there's a precious pregnancies and the patients really want to know about all of this. So these are early days yet, but that was a little peek into what future holds for us as far as cardiac and neuro remodeling in FGR is concerned. So my next question, what are the drawbacks of computerized CTG? Now I see a lot of fetal medicine experts and a lot of gynecologists relying too heavily on computerized CTG, which is not really bad. But then what are the drawbacks of such an investigation, Dr. Pooja?
You mean regular CTG rather than...
Yeah, a regular CTG rather than a computerized one, because a computerized is not as common and easily available yet. But even for a normal CTG, the answer lies in the sequence of changes that happen in a fetal growth restriction, which has been beautifully provided by Professor Ahmed Behshat. So he's clearly mentioned in a lot of more studies that the Doppler changes precede any changes on the CTG or biophysical profile. In fact, by the time the CTG shows changes like decelerations or non-assuring CTG, the acidemia level in the fetus has reached a point which is going to do more harm to the fetus than if we would have intervened on an abnormal Doppler. So these are the reasons why you should rely more on Doppler rather than CTG for decision making. Intrapartum, yes, CTG is excellent, but for decision making to deliver or not to deliver due to the high false negative as well as the false positive rates of a CTG, it is a Doppler which is a better decision maker tool along with the fetal weight and AFI and the gestational age as compared to a CTG.
So now we come to biophysical profiles for critical decision making, and I think through the 3 lectures and through this panel, we know for sure what are the answers, but then Jimit, you can just quickly summarize it in 30 seconds or so. Why have you largely stopped using BPD or biophysical profiles for critical decision making?
So the biophysical profile is abnormal only when the fetus is already compromised. Today we have better tools like color Doppler monitoring, which is a better predictor, more accurate.
Much more sensitive. Much more sensitive.
And apart from diagnosis, it can also be used in monitoring the fetus. Takes much less time, and also serial color Doppler studies help in decision making. Dr. Vivek,
some of the large studies have really shown that the Doppler has been able to pick up a hypoxia or a critical stage 7 to 10 days earlier than the changes in the biophysical profile in the fetus. So we need to know much before what is happening to the fetal status. So Dr. Chander, now finally moving on towards the end, how do the Barcelona algorithms facilitate decision making?
Well,
I know you've already...
Yeah, actually, I've already spoken about it.
Yeah.
There are simple tools you have in your mind. You don't always go to the Barcelona algorithms. It is essentially a guide for dummies to, put in your data on the computer and wait for an answer. Most of us who are already doing a lot of ultrasound don't go necessarily to the computer, but it's objective. If you need criteria, you have some guidelines from the Barcelona guidelines, and you can put in your data, get an objective answer, and it can support your decision making. So in today's bad world of medical legal situation, sometimes you need these objective criteria, and it can be accepted as an appropriate objective criteria that we have used this criteria. But at the end of the day, like I said, when you know all the criteria, if you've seen an absent end diastolic flow, you know you're in stage 2. If you see a reversal, you know you're in stage 3, and then so on and so forth. So these these are already in your mind, but definitely we do use them.
So you've already tackled the second question also
Yes.
in your talk earlier on how do you decide when to deliver in FGR. But the key point here is that Barcelona algorithms can help you, but the point is that we should not follow all this blindly. We should take a decision based on several inputs and make a wiser decision like that.
Yeah, you should look at your local setup also. You have to have your local neonatal setup, your local criteria for delivery should also be incorporated in that. Can I just say one thing? There is a lot of questions coming for Pooja on why not to date on CRL in an IVF pregnancy. I think that you should answer because I saw at least 10 questions.
10 questions. Yeah, more than that.
So
Okay,
Pooja,
so first,
I think
when I saw them, a lot of them are actually asking how to date an IVF pregnancy. All our ultrasound machines as well as our softwares have got various ways of entering the history, of which the commonest one which we use is LMP. Okay, as soon as you enter the LMP, it gives you gestational age today and EDD. Yeah, that's the commonest. But in an IVF pregnancy, like I said, we do not rely on LMP. What we actually do is we click on the button of LMP and it will give you further subheadings, one of which is date of conception. Okay, in an IVF pregnancy we are sure about the date of conception, so you click on the date of conception and then you go back and ask the lady the date of embryo transfer. To simplify things, on the day when the embryos are transferred into the womb, the age of the embryo is already 2 weeks and 3 days. I'm considering a day 3 transfer. Okay, irrespective of a fresh or a frozen cycle, a day 3 transfer, when you put in the embryos, the age of the embryo is 2 weeks and 3 days. So considering that, if suppose the embryo transfer has happened on 21st of April, I put the date of conception as 18th of April. Okay, and that is how I will date this pregnancy and never touch the dates again. Okay, so and why we should not date such pregnancies by CRL? Although CRL is the best mode to date a pregnancy in an otherwise situation, but in IVF we are very sure of when the conception has happened, and that's the best way to date a pregnancy. So we should not go by the suboptimal ways.
So which means that if we go to CRLs again in 12-week scan and suppose there's some discrepancy, we will miss out.
We'll red flag the patients. A lot of them are elderly mothers. ICSI with an abnormal male factor increases imprinting genome disorders. You need to keep all that in mind and just red flag these pregnancies.
Correct. Thank you very much. Now there's another question which is persisting, and if you allow us, let me take one from Bangladesh. And he's a radiologist, Dr. Justin Klump, and he wants to know that if the patient has come in for a pregnancy profile, she does not remember her LMP. Now, this is a very, very common scenario. The BPD is corresponding to 28 weeks. The femur length measures 22 weeks only. The abdominal circumference measures 23 weeks. Fetal weight is in the 14th percentile, and fetal cranial indices are normal. No brachycephaly. Now, what should I write as gestational age? Now, this is one little question which is, Dr. Chander, I would love you to tackle this. I mean, it's the BPD 28 weeks and the rest is 22 weeks, 23 weeks.
Okay, so first of all, she doesn't know her LMP, so I don't know how he got a percentile, 14th centile. That is something I don't know, but you cannot get a centile if you don't know the LMP. Now the question is BPD 28 weeks, FLL and ACR 23. I think he should have taken a head.
Yeah, fetal weight.
He should have taken. Yeah. He should have taken a head circumference rather than taking a BPD alone, because the head circumference is more specific than the BPD alone. He has also mentioned that there is no brachycephaly, in the sense that that means there is no head shape. So presuming that the head circumference is also 28 weeks, I would look for some other criteria, right, like the cerebellum or something like that to date this pregnancy, because obviously there is some confusion. You don't have the LMP, you don't know whether this is a large head, that's why it is 28, and this is actually a 23-week pregnancy from the femur length or the abdomen. So I would look at the cerebellum, and if the cerebellum is normal, 23 weeks, I would date it as 23 with a large head. I would look for abnormalities. But if the cerebellum also is larger, then I would be worried about asymmetric growth restriction and look at the Dopplers there.
But then
I would refrain
macrocephaly
from dating her. Sorry, sir. I would refrain from dating her on the first visit right now, because the BPD does not agree with the FL. I would tentatively date her, as in put into brackets that today the gestational age has been calculated using the head circumference, but shall be confirmed if there is optimal interval growth after 2 weeks. So that would finally give us an EDD.
I think there's been a barrage. There's been a barrage of questions, and I don't really know, Dr. Chander, how to tackle all of this, and we feel really sorry because we've run out of time. If permitted, can we answer all these questions and post them somewhere, maybe on our www.imagingmasterclasses.com, and then maybe somebody who wants to really know these answers, we can always put that. But there's one question which is really intriguing and which I want to read out one quick before we finally wind up, is that how accurate is gestational sac diameter in the first trimester for dating? So that comes from Devyani. Gestational sac for dating.
No, we would not use a gestational sac for dating anymore, except for cases like what you elicited, sir, in the triploid or the trisomy 13, mostly a CRL. See, the whole point is over-utilizing what we already do rather than adding on more numbers and nomograms and charts and scans. A lot of people do not even do a viability scan. They don't have protocols. They just scan for the first time at 12 weeks. When you're already over-utilizing this window for doing a nuchal and a CRL, and we know that CRL collaborates so good with the gestational age, let's stick to dating the pregnancy with a crown rump length rather than any other parameter, unless in an exceptional case.
So, Dr. Pooja, one question that a lot of people are asking: what is the ideal time for dating the CRL?
For dating,
what would be the
anti-scan between 11 and 13 plus 6 weeks? Yeah.
45 to
I would just like to make a final comment, if you may say so. I yet think CRL is the best dating thing, as was discussed earlier, but you have to be very careful. Do a very good anatomy scan. If you find anything wrong in the anatomy, please don't use that CRL for dating. Or if the CRL is more than 1 week smaller than the fetus LMP, then please don't use the CRL. So it's very important that you do good ultrasound and then date the scan from the CRL. Otherwise, CRL is the best dating way of dating a pregnancy.
So, Dr. Chander, we have 127 selected unanswered questions. So they are unanswered, but they are selected also. So 127 of them, and we don't have time for that. And this shows
I think
that
we did answer in all the 3 lectures. We did. If you replay this webinar, which I'm sure G is always doing that all the time, you will get most of your answers, because very carefully all the lectures have been
tailored for that.
Tailored to see that all the questions. As I see, a lot of questions have already been answered, but suppose somebody may have missed it or something. I only want one more question, all of you to answer, because a lot of people are asking that if the fetus is 36 weeks and CPR is less than 5th centile, would you deliver?
That was the situation we were discussing earlier in one of the
so I just, because every conference I go to, everybody asks the same thing, that if the CPR is less than 5 percentile, if you have a normally sized baby, what would you do? So can we have the final word on that? Pooja, Vivek,
how many
and
weeks
Jimit.
You said? How many weeks?
36 weeks. 36
I think deliver.
weeks.
I think deliver.
I shall deliver 2. Although,
Yes.
like you said, Prof has underplayed the role of CPR, but the final word is not out. But in a normally growing fetus with a CPR less than 5th centile, you are nearing 36, 37 weeks. These babies are the ones who do not have time for central adaptation, and we may just lose them suddenly, and then we have to come out with things like cord around the neck and all. So we just deliver
would you
them.
do a cesarean, or would you do a normal delivery?
No, I would assess the bishops. I would give her steroids, and I would give her a trial, a short trial. But there's no indication for a cesarean. Yeah.
Jimit, what's your final word?
So would we be looking at other parameters or just the CPR?
No,
Independent.
just the CPR. Yeah, uterine artery is normal. Everything else is normal.
Aortic isthmus.
Absolutely normal.
Okay, then.
Maybe a little bit reverse.
In the current scenario, sir, better to deliver.
Okay, the three of you say I would watch because CPR has a lot of fallacies. We need to watch. So I would intensify my monitoring at least twice a week. But I agree with you. I mean, it's a very dilemma question what to do at 36 weeks with a low CPR. So let's leave it at that. Vivek, I congratulate you for a wonderful web symposium. I think you need to do one more to really cover all the aspects, and I look forward to that.
Absolutely wonderful, sir. Thanks to all the participants. Thanks to Dr. Chander, Dr. Pooja, Dr. Jimit for being there. I think this has been a wonderfully successful endeavor, and we look forward to many such more series where we pick up a theme and we try to tackle it. And another thing is that it's already 10 p.m. We were supposed to finish in about less than 2 hours. We started at 7:30 sharp, and look at the time, and still unanswered questions, unanswered cases. So I think we'll be better prepared, and the audience will be better prepared next time. Thanks to GE. Zinat, would you like to take over now? Thanks.
Thank you, faculty.
Thank you. A big thank you to all the faculties here, Dr. Chander, Dr. Kashyap, Dr. Pooja, and Dr. Jimit. Big thank you. We have got a very good response. I'm seeing there are so many questions unanswered, but definitely we have a way forward. We will, and Dr. Vivek will answer all the questions. He will take a lead on that. Thank you very much. Thank you, audience, for joining in with us. Good night and stay safe. Thank you.
Good night. Good night.
Good night. Bye.
Thanks.